Well, good morning. It's great to see everybody, and welcome to the second annual meeting of the Implantable Brain-Computer Interface Collaborative Community. Really excited to see everybody here this morning, and really excited to be doing this in concert with the 150th annual meeting of the American Neurological Association that starts today right here in Baltimore. And so we're going to begin today by launching our 148-year plan for the iBCI-CC. It is kind of amazing to think, what will implantable brain-computer interfaces be 148 years from now? You know, bold goals require bold plans. So I guess this is where we'll start. We won't be quite that ambitious today, but it's the people in this room, as well as the people online, who have really been helping to move this field forward, thinking about what the next steps are, and really getting to the point that these implantable devices will be available to help people with neurologic disease or injury. Take a brief moment to thank our Iridium sponsors who are listed there on the screen. These are our first Iridium level sponsors for the iBCI-CC, and maybe we'll just take a moment to thank them for everything that they've been doing to keep our organization going. There are some representatives of those institutions in the room, so please take a moment to thank them in person. All right, with that, my job, and I'm told very carefully to help to keep us on time today, we'll briefly just show you the agenda, which looks a little pale from where I am. If that's the only slide that's pale, we're going to be just fine. I'll look to my colleagues in the back. Mike, what do you think? Any magic dial? No, nothing. We're just going to keep it that pale. You have either online in your booklet or in front of you, if you're in the room, the agenda for today. And my job is really just to welcome you and keep going. In a little while, you will hear from my other colleagues, co-organizers of the iBCI-CC, Jessica Kelman, Jen French, Joe Lenners, and you'll hear from all of us in just a little while. But thanks for being here, and I'm going to keep us going. Our welcome today is going to be from Dr. Michelle Tarver. I know that Dr. Tarver wanted to be here. We were close to scheduling it. The plane that she's on either just landed or is about to land, and there's all kinds of hopes that she could do this live. But in either direction, I think she wisely decided to provide an opening video for us. When I first started to hear about collaborative communities just a few years ago, trying to figure out how could a collaborative community help all of us in the implantable brain-computer interface field, one of the first conversations that I had was with Dr. Tarver. And right from the start, it was just immediately clear, as she was describing to me some of the early days of the collaborative communities, how these types of organizations could help us to achieve the many goals that we have for this field. Dr. Tarver, of course, is the director of CDRH, and I am really excited to allow Dr. Tarver to welcome us all today.
Good morning, everyone. It is truly exciting to be with you virtually today. Having been part of the initial conversations around the formation of the Implantable Brain Computer Interface Collaborative Community, it's truly a full circle moment for me to be joining you all for the second annual meeting of the iBCI Collaborative Community. I'm honored to share some thoughts on the importance of collaborative community efforts like yours and how they move science forward to improve care for patients. At the Center for Devices and Radiological Health, patients are the first word of our vision because our work begins with and ends with the people who are most impacted by medical devices. Our center is committed to assuring that patients in the U.S. have access to high-quality, safe, and effective medical devices of public health importance first in the world. Our vision does not signal a competition with other countries, but rather it inspires us to work tirelessly towards timely patient access to devices that meet FDA standards. As I am sure you all know, we're in a time of significant transformation in healthcare and how that healthcare is experienced in this nation. Hospitals and clinics are closing, fewer providers are delivering clinical care, and chronic diseases are on the rise. At the same time, we are seeing an explosion in technological innovation with miniaturization of medical devices, increasingly sophisticated software and algorithms, and the opportunity to venture into new frontiers. We've already seen exciting stories in the media where implantable brain-computer interface devices are being used to help individuals feed themselves, communicate by typing messages, or play games like chess or Guitar Hero. But the true potential of this technology lies in its ability to optimize a person's quality of life. Imagine regaining functional independence, being able to better communicate with family members, friends, and care partners, being able to direct your own care or manage daily activities that many of us take for granted, like ambulating or performing bladder and bowel care independently, pursuing personal goals like working or volunteer activities or engaging in hobbies. And beyond these measurable gains, being able to jump into a conversation, to tell a joke, or to simply say, I love you to the people that matter most. These are the moments that define the human experience, and they are within reach. As these transformative technologies continue to develop, it is important that we do not become intoxicated with the promise of technology without also soberly considering the risks and unintended consequences. This balanced conversation can be facilitated through collaborative communities. Collaborative communities are ongoing forums where private and public sector members, including the FDA, work together on shared medical device challenges to achieve common objectives with broad impacts. They promote a shared responsibility for results and create meaningful, real-world outcomes. These collaborative communities work well when they create an environment of trust, respect, empathy, and openness. CDRH currently participates in 18 collaborative communities, and we continue to receive requests to participate in many others. The iBCI collaborative community plays a crucial role in accelerating innovation across the total product lifecycle, or TPLC, by creating a meeting place for expertise and perspectives, those perspectives that are needed to responsibly move groundbreaking technologies forward. Over the past 2 years, the iBCI collaborative community has generated noteworthy works, such as developing a frequently asked questions webpage, creating a summary document of gaps in current standards to identify what could be addressed more urgently, working on a survey to better understand the important concepts of interest that could be assessed by outcome measures in future clinical trials, launching a neuroethics resource hub, drafting an informed consent checklist, and generating a cost consideration and coverage analysis white paper. Together, these deliverables will help educate the public and potential users in understanding BCI use cases, create a common lexicon about these devices, as well as consistent communication of critical safety information across all clinical trials, identify gaps in understanding, and illuminate opportunities to learn, work towards developing potential outcome measures, and lastly, improve the field's ability to provide important information to the Centers for Medicare and Medicaid Services about the unique considerations related to reimbursement in this device space. iBCI is a device designed to be largely experienced at home and integrated into a person's daily life. At CDRH, we recognize the urgent need to support clinical care that evolves beyond traditional settings like the hospital or the clinic. We must meet people where they are. As the U.S. regulator of digital health medical devices, FDA is uniquely positioned to bring together stakeholders across the ecosystem to create meaningful momentum. This is the drive behind our initiative, Home as a Healthcare Hub. We believe a fundamental shift is needed, a shift in how and where we deliver care. It is critical that we design systems that meet people's needs in their homes and communities, not just in the hospitals and clinics. To jumpstart the conversation, we have created an Idea Lab to help catalyze innovation that will enable all people to optimize their health where they live. The Idea Lab includes virtual reality prototypes of different affordable home models to provide a tangible look at the challenges and constraints of people navigating their medical conditions with medical devices in their daily lives. We started with example homes of people living with diabetes, given the prevalence and burden of that disease, and the role of medical devices and lifestyle in managing the condition and preventing comorbidities. We also know the impact of the disease on multiple organ systems, and the mobilized patient organizations and provider groups can help fuel and well-position FDA to contribute to solutioning. Through the Home as a Healthcare Hub initiative, we're laying the foundation for integrative, person-centered solutions that move care into the environments where people live, work, and play. We see this prototype as an opportunity for medical device developers to walk in the proverbial shoes of the patient at home and design, keeping in mind how people live their lives, not just designing to treat or manage a condition. For people living with conditions that may benefit from iBCIs, this could mean intuitive, seamless control of assistive technologies at home, allowing individuals to express needs, adapt environments, and live more independently. Collaborative communities are an important way to help us realize this future state. From collaborative communities in which we participate, we have seen outputs such as peer-reviewed articles, tool development, harmonization on definitions that can help move fields forward, roadmaps to help point the way for developers, clinical practice guidelines, and oftentimes, and most importantly, the kindling of relationships that are necessary for implementable and adoptable solutions. Let me highlight a few examples from other collaborative communities, and I hope you take them as some inspiration. The Advancing Quality Excellence Collaborative Community generated a white paper on improving how corrective actions and preventative actions could be undertaken in manufacturing of medical devices. The Wound Care Collaborative Community put forward a publication on reporting results of wound healing in non-clinical studies to support medical product development. The Heart Valve Collaboratory has multiple publications, including landscape analysis and a research agenda, as well as definitions and clinical trial endpoints to help accelerate innovation and treatments for valvular disease. The Collaborative Community on Ophthalmic Innovation has multiple publications on innovation in the ophthalmic space, including a paper on artificial intelligence using ophthalmic images that helped advance the use of AI, especially when AI began to grow substantially in healthcare. And lastly, the iBCI-CC Collaborative Community published core measures in Alzheimer's disease and related dementias, physical activity, and sleep, as well as an interactive guide to validating novel digital clinical measures. Some of these outputs may help fuel advances across the healthcare ecosystem and hopefully will spark ideas for the iBCI Collaborative Community. The value of collaborative communities is clear. They are places where interested parties can identify the gnarly challenges, set audacious goals, engage in robust scientific discourse, and tailor appropriate solutions. It's not easy work, and I applaud you all for taking up the challenge. We look forward to continued collaboration with your community as we all work together to ensure medical device innovation serves the real lives of real people wherever they are.
Well, if that wasn't a message of inspiration, we don't know what to say on that one, right? So big thanks to Dr. Tarver for giving us that message to kind of set us forward as we embark on our second annual meeting. She really gave us some thoughts on not only the projects that we've completed so far, but those that are underway, and also some thought about how we can move the field forward with other outputs. So I'm just going to go a very quick introduction to the iBCI-CC. For many of you, it might be a reintroduction, but we just wanted to set the table for who we are, what we do, and what we are comprised of. And of course, I want to recognize you already heard from Lee, but you will also hear from Jessica Kellerman and from Joe later on today. There we go. So we are made up of diverse stakeholders, not only those who are in industry and research and academia, people with lived experience, patient advocates, ethicists, and more. And that's what makes us incredibly unique in the fact that we bring together these stakeholders that typically don't talk to each other, but actually pull together to help move the field of implantable BCIs forward. We do want to recognize Mass General Brigham for being our convener and appreciate what they do for us to setting the backdrop for us, but also the charter signatories. Many of them are in the room as well as online for helping us to found this. And of course, we are now at nearly 500 members, which is incredibly exciting, and how we can bring these diverse perspectives to move the field forward. Just as a reminder, we do operate in what's called the pre-competitive space. So this is an area, as I like to call our sandbox, and we play in the sandbox together so we can move the whole field forward. Anything that looks at very specific areas are outside of our sandbox, but remember, we are all playing in the sandbox today and collaborating. I don't think it's anything new for many of these in the room is that we have a rich history in the development of implantable BCIs going all the way back to the 1960s. And I won't go through the history of this, but really we fast forward today and we are at a pivotal time of the development of implantable BCIs. And we have a lot of commercial interests. And how do we bring that forward to make it widely available for clinical use? And we have a lot of outstanding questions that are still before us today, like what are the right outcome measures for implantable BCI clinical trials? How do we ensure that health insurance companies cover the cost of implanted BCIs? What are the daily challenges and priorities of people who could benefit from BCIs that have lived experience? And how do we learn from them? And also, how can we better educate the public about BCIs? And of course, there are a slew of other questions. And that's really where our space comes in as the collaborative community to help set that forum to help us answer these questions to embark on this new technology. And how we do that is we work in work groups, which you will hear a lot about today. Jessica is going to give us an update of where we are in our work groups. But those work groups, our 7 work groups, are designed to answer a lot of these pivotal questions that are facing the industry today. And we do so by producing outputs. Dr. Tarver mentioned some from other collaborative communities. You will hear from Jessica in just a moment of how our work groups are moving forward. But think about this as we embark into the afternoon in our breakout sessions about what type of outputs we can produce to be able to set the level playing field for the industry. So with no further ado, we do want to let you know that if you are not a member yet, please join. If you have colleagues who are not members yet, please join. And you can do so by visiting our website and just clicking on the join button in the front. So with that, I would like to hand over the mic to Jessica that can now give us updates of what we've been doing in the past year. Jessica.
All right. So I just want to provide a high-level overview on what we've been up to over the past year or so. So I'll start all the way back to a year ago when we had our first annual meeting over in Silver Spring, Maryland. And this was a very successful meeting. We had a lot of really great discussions in our breakout groups, and many of the work groups made plans for what projects they would be working on over the course of the next year. And I think we did pretty well in terms of working toward our goals and making progress on the issues that we set out to resolve. And so kind of to summarize that, our progress in numbers, we are at up to 490 members, and we have had collectively 71 work group meetings across all the different work groups. And we have identified 40 projects, 18 of which have been completed, and 2 of those include public outputs. And many of these projects are incremental internal projects, but they're all working toward external outputs that will be able to contribute toward the field moving forward. So if you're interested in learning about any of those projects in a bit more detail, we published them in our annual report, our first annual report in March. So that's available for your reading pleasure on our website. So you'll find summaries of what our work groups are up to, updates on our goals and progress on them, as well as a financial summary. So I did want to focus in on one particular special project that we've been working on, which is the iBCI-CC glossary. And this was a cross work group effort. So every work group worked toward this glossary and contributing terms that was relevant to the topic that they were speaking to. And the point of this glossary was really focused on lay accessible terms. So we included technical definitions, but our goal was not to be the source truth of these definitions, but rather kind of collect them all together. We referenced other more technical sources that have the definitions and then built lay accessible definitions just to kind of lay the groundwork and make sure that we're all operating off of a shared understanding. So this glossary is now available on our website, so you can go and check it out. You'll see that it says version 1.0. It's not perfect. Our understanding of these terms will continue to evolve. And of course, there may be competing understandings. So if there's anything that you see that could be improved upon or any terms that you could add, we do have a link to a form on the website so that you can submit your input on what changes you'd like to see to it. So I just wanted to highlight that because that was a major project across all the work groups and really showcased how we can all collaborate together to come up with an output. Another thing I wanted to highlight is that we started the iBCI-CC Fundamentals webinar series, and the goal of this webinar series is to lay foundational knowledge for many of the issues that we're trying to resolve within the iBCI-CC. And so these have covered a span of topics that may speak to particular work groups especially, but is also targeted toward all of our members at the iBCI-CC. And we've had great attendance at these webinars. We've had really fantastic speakers, including Marcy Wilder a couple days ago spoke. I think she might be here somewhere. Not immediately seeing her, but thank you, Marcy, for doing a great talk a couple days ago. The other talks that we've had have covered topics such as clinical outcome assessment development, understanding the market opportunity for iBCIs, incorporating the lived experience across the total product lifecycle, and then the most recent one was on neural data and HIPAA. And so we are continuing to have these webinars. I think they've been really effective. So if you have any ideas of topics that you'd like to learn more about, or that you would think speak really well to issues that we're working on in this community, definitely feel free to reach out to me and we'll work on incorporating that in. And then another initiative I wanted to highlight is that we launched our first summer internship program at MGH. So we had Joyce Chen and Caleb Ju join us. Joyce Chen is actually here with us today, so I'll use this as an opportunity to do a shout out to her. Both of them were an excellent help over the course of the summer in preparing for this meeting and aiding the work groups in working toward their goals and running the meetings. So I think it was a really effective program and I hope also very enriching for the students. So it's something that we'd like to keep going forward with in the future. So if any of you are interested, there are sponsorship opportunities to maintain this program. And then finally, I'd like to highlight how the work groups have been actively engaging in the community. And the work group co-leads will, after me, come up and talk to you about what they've all been working on. So I won't go into too much detail about everything they've been doing, but just to highlight some of the events we've had some events that were geared toward taking outputs and projects that the work groups have been working on and bringing them to a collaborative community forum or a forum outside of the collaborative community in order to get feedback from other stakeholders on the projects. And then we've also had initiatives to provide education to patient advocacy groups and people with lived experience. And so just kind of quickly, these involved, we're at the BCI Society, the Clinical Study Endpoints Work Group, helped run a Concepts of Interest workshop. We're at ASNR, and we had a couple of different events there. So the Clinical Practice Guidelines ran a workshop there. And then we also had the User Priorities run a symposium on user journeys. And then finally, the Public Messaging work group helped prepare presentations to help educate some patient advocacy orgs. We had a webinar at the Christopher and Dana Reeve Foundation, and we also had a webinar at the ALS Therapy Development Institute. All right, so we have a busy slide. Oh, good, I thought this one might be pale like some of the others, but it is not. But yeah, don't feel like you have to read all the text on here, but it's really just to kind of showcase all of our work coming to fruition. These are just a handful of the projects that we've been working on, but these are some of the key projects that are nearing completion within the work groups. And so as you can see kind of with the rainbow of colors that we have going on, we have a lot of different types of outputs coming from the different work groups. And these will be really great outputs in working towards solving some of the key issues in the iBCI field. And you'll hear more about the specifics of these from the co-leads, so I don't want to steal their thunder by going through them. All right, and then I will go ahead and hand it over to Dr. Lee Hochberg, who will talk about what else we have in store for the year ahead.
Thank you, Jessica. All right, so let's continue to hear a little bit about not just what we've been doing, but where we're headed. So we're now about a year and a half old. We were, I think, chartered in March, I can remember, of 2024, plus or minus a month. And now that we've completed our first full year, really thinking towards the future. First, right up the top, as Jessica was just telling us, our work groups have been making great progress. We spent a bit of time in particular over the past few months and later today, really focusing what are the top priority projects for each of the work groups, how are we going to make those happen, how are we going to achieve those deliverables, particularly in some of the discussions that I will, of course, lead to the work group co-leads that I'm going to be presenting in just a little bit. We're going to form a steering committee. That steering committee is going to provide feedback to your co-organizers who are sitting in part up here. And in addition, we're going to continue this fundamentals webinar series, which has been so effective. If Marcy may be able to appear later today, just a great presentation a couple days ago on neural data and HIPAA. It was kind of the 101 on neural data privacy from a legal standpoint, and we're all looking forward to 201 and 1220 and really digging in deeper to this important topic. Going to continue to expand our outreach. Thanks again to the American Neurological Association for the chance to be here today. We have ongoing advocacy organization engagement. We all know that this field is growing. What counts as part of this field is growing, and we're going to wrestle with that and really look forward to, I believe, expanding to some extent the many people who we are all trying to help and the diseases and injuries that they have. So this, as many of you in the room know and may have been working on as recently as an hour ago, there are new pilot trials that are about to launch. They're the first pivotal trials in this implanted BCI field that we all hope are going to be launched sometime over the next year or so. And we as a community are here to hopefully play an important role in shaping the field and shaping as we can and informing the design of those trials and of course helping however we can our regulatory agencies and thinking about these trials. So thanks for the outstanding animation. That was great. So what we're hoping to achieve is to really think, among many other things, about these outcomes assessments. Really, in many ways, part of the reason that we all got together is to think about this challenging issue of what are the right outcomes assessments and measures for implantable BCIs? What are the clinical best practices on the way towards future guidelines? How do we think about reimbursement in this novel field and so many other important questions? So with that, only 2 minutes behind, but we started at 8:32, I'd like to point out, so right on time. We are really excited to transition to the beginning of our work group presentations. And is this where I invite up Adina? Yes, it is. All right. And Adina, I know I saw you. You're here. Adina, I think I saw you. Yeah, oh, hi, Adina. So we are very happy. I think I interrupted breakfast. Sorry. We are really excited to hear the 8-minute presentations from each of our work group co-leads and/or their representatives. And we'll hear first from Adina Bradshaw on user priorities, preferences, and iBCI use cases. And I'm handing this to Adina. Is that all right? That's yours.
Didn't realize I was going to be first. Apologies. Just pull up my notes. So, hi, I'm Adina Bradshaw, speech pathologist and the Chief Impact Officer at Team Gleason. I guess, do I change the green one? Thank you. Not prepared. There we go. Okay. On behalf, well, good morning, everyone. Hope you had your coffee. I'm still drinking mine. Good morning, everyone. And on behalf of Ian Burkhart and DJ CO, the co-leads for the user priority group, I'm happy to present our update on the progress for the last year and what we have planned for ahead. You can read the overview in the agenda. So there's no, we don't have the slide, but essentially our work group's primary goal is to ensure that iBCI is aligned with the needs, preference, and daily realities of the users, including people living with neurological conditions and their care partners. We believe that successful development and deployment of the BCIs depend on prioritizing these end user needs. And in the past year, we've seen our work group grow from 103 members as of March 2025 to 150 members as of September 2025. And we've had 10 very productive meetings, I feel, and some webinars. So yeah. In the last year, we've completed go through those. In the last year, we've been running through the use cases, going through the use cases of work groups, and we led a successful literature search with a very large library that was very comprehensive, and appreciated everyone looking through all the literature. The key takeaways were consistently that communication, speech messaging is rated the most valuable iBCI use case and seen for it's important for maintaining all of, well, I guess you could read all that text. We went through this for maintaining autonomy and in private tasks, and also the desire to design features for such as caregiver alerts. But crucially, users really want to be introduced to the iBCI technology when it becomes functionally and necessary, not at the point of diagnosis. They want to know it's available, but they want to be introduced to it. For caregiver and family priorities, there we go. Yeah, I'm going off two different ones, so apologies. This is, user successful development. I already did this. Sorry, my apologies. That's why I don't go first. We'll keep going through this. And then the caregiver priorities. Caregiver and families wanted earlier introductions, and then researchers and clinical priorities, we discussed those. Some additional insights were that research shows that family members and clinicians prefer intracortical iBCIs over non-invasive ones. And then this is a summary of the of all of the use cases. And then we worked on user journey mapping. We have several of these maps that are available in the iBCI work groups Dropbox. And I know it's a lot of text. It is linked in our Dropbox if you want to look at them all. These were very comprehensive. We successfully documented and detailed the end user journey experiences for people living with ALS, spinal cord injury, stroke, and CP. In the categories that we looked at, the journeys outlined evolving physical, medical, cognitive, emotional, social, adapted lifestyles and assistive technology aspects across the different stages of each user journey. And then key insights in this mapping identified that user priorities change significantly over time based on the evolving condition and the impacts. And so we want to address holistically all of those changes. We also identified the standardized visualization template. As you can see, a lot of text, but we have it for every one of the different user experience. So CP, and then one of the ones that we added, I'm going to go back one. So we added, based on feedback from our work group, brain injury. So we are currently drafting the brain injury user experience, if anybody wants to assist with that. And then for the next future work group projects, we've identified these user journeys, and we're planning to publish these stroke, ALS, CP, and SCI. But we also, in working through these user journeys, we identified gaps in the literature. And what we want to do is work through more of a holistic view of the priorities by looking at gray literature and validating some of the preferences and priorities that we found in the research. So that's where we're going to work on that through mapping a larger effort to map a holistic priorities, and then also surveys from the community. And yeah, I think that is it. Oh. Yes. Oh, that's the traumatic brain injury one. Sorry. The traumatic brain injury one, we did start this one. So if anybody here would like to work on the brain injury one, please let us know. And we still remain committed to ensuring that BCI is deeply user-centered and has all perspectives for every use case. So anything you would like to contribute, please contact us. And I think that's it. Thank you.
All right. Thank you, Dina. And I will just highlight that those user journeys are going to be incredibly important across all of our work groups in informing our thinking about concepts of interest, which will then, of course, help us to be identifying the clinical outcomes assessments and the goals for some of these upcoming pivotal trials. So with that, moving right along, really my pleasure to introduce Devjani, who's going to come up, and Vivek there together, who are going to be telling us a little bit about the clinical study endpoints work group.
Okay, great. Thanks, Lee. Thanks, Jen and Jessica, too, for letting us participate here. Just a little background, I'm Vivek Pinto. I'm the Director for Medical Affairs at Precision Neuroscience, but I was at the agency for 12 and a half years, most recently in the Division of Neuromodulation and Physical Medicine Devices. Devjani and I worked together for quite a while there at the agency, mostly in Physical Medicine Devices branch. And one of the biggest challenges that we really had in a lot of these discussions and decisions was just trying to decipher the meaning behind these different outcome measures and whether there was a clinical benefit. And, after seeing kind of firsthand the outcomes of those decisions, whether it's for payer coverage or trying to get, clinical adoption, it was a little disheartening with the TAP program to see the outcomes that there was really a lot of failures with getting that broad clinical adoption. And a lot of things go back to our thoughts, perspectives on these clinical outcome measures. So, there's a lot of reasons that kind of go behind that, but the choices that you have is so vital with these study designs, and the regulators have a really tough time trying to decipher these, but hopefully with everyone working together, we're gonna be able to give them very valuable insights. And then also, down the line, these are going to be meaningful to all the stakeholders that are going to be using these. So just to kind of go back to, what our work group objectives are. Like Devjani and I are newly appointed colleagues, so we're kind of picking up the baton. Our objective as a group is to establish clinical endpoints for implantable BCIs that are considered clinically meaningful and can be leveraged for regulatory approval and to drive product or clinical adoption. But they're not without their challenges. We have a lot of different use cases, and so different endpoints vary depending on that, and they may be appropriate for some and not other cases. There's different levels of validation that they currently have. And also, one kind of subtle thing is these are novel technologies, so there could be knee-jerk reactions to, just trying to focus on past examples versus creating. And so we're kind of all challenged between all of these things. But there's been a lot of accomplishments that Johnny's going to go over those and the things to come the next year.
Hi, everyone. Good morning. So just the progress that we've made over the past year, I think Jessica as well as Lee kind of alluded to these, but we've had several projects. One was basically looking at case studies of clinical outcome assessments and then looking at those that are kind of more established. So specifically, there was a case study on retinal prosthesis and trying to understand when there was a technology that was novel, how were the endpoints evolving in order to get regulatory approval and kind of that pathway. There was also a project to develop a list of attributes that were considered ideal for a clinical outcome assessment for iBCI. So things like, it needs to be simple, it needs to be short, it needs to be able to reflect functional daily activities, day-to-day function, and it needs to also capture the user's ability to feel, functions, and survives, right? And then there was a lot of work put into developing a matrix of existing outcome measures. There was a ton of people that really dived into the literature. This was led by Adam Fry, Kristen Welly, Dan Rubin and team, and they took a lot of time to look at the clinical literature and kind of put together existing assessments that have been used and categorize them by particular domains of function, as well as categorizing it by functions, feels, and survives. And the intent is really to publish these outcome measures as kind of a living document on the iBCI website that continue to evolve and grow as the field grows. And then, when we look at these outcome measures, our first question was, okay, well, how do we understand what's going to be more or less meaningful to these patient populations? And when we started to have these discussions, FDA recommended using a conceptual framework that was based on two main concepts, concepts of interest, which basically they're aspects of health that can be affected by these medical devices, and these contexts of use. So how are these outcome measures being used? Things like the target populations, what is the intended use of the iBCI, the setting, who are the people that are going to be using these outcome assessments. So all of the intricacies that kind of are reflected in some of the study design considerations. And then when we started looking at the framework, we started to understand that once these clinically meaningful concepts of interest are identified, then we can start to map these outcome assessments that we collected in that matrices and try to match them up in order to see what outcome assessments can be captured, can capture these meaningful concepts of interest, as well as for trying to understand what the gaps are, right? Where are we missing? What are certain concepts of interest that we don't have clinical outcome measures in? So to that end, Dustin Herman and team, they took the first shot at developing a list of concepts of interest for specific functional deficits. And let's see, next one. And once we have this list, what the goal of the breakout session for those who are going to be attending it is really to try and finalize this list to get it to a point where we can start to survey the clinical endpoints working group in order to understand what are clinically meaningful outcome or concepts of interest. We're also going to utilize some of the output that the user priorities preference working group has. So in order to really understand, like, did we capture the right ones? Are these the concepts of interest that we're seeing from the output of the user priorities working group? And once we have those that are considered clinically meaningful, then we're going to start to really match those outcome assessments that we developed from that matrices and that we compiled. And then, then there's also that work of understanding how are these outcome assessments validated? What kind of evidence do we have to understand its reliability, interpretability, constructability, all of those things. And then with regard to publications, we hope to put out a methodology paper kind of based on that conceptual framework of kind of identifying what these concepts of interest are, as well as how do you map it to get to clinical outcome assessments that may be considered clinically meaningful. And then we're also going to obviously hopefully publish a paper on these concepts of interest, as well as these clinical outcome measures for specific contexts of use, so, and the existing gaps that might be there. So I'm really looking forward to continuing our work on this. And that's all. There's a question. Do I take questions? Yeah.
I'm the pleasure of the former CEO of CMS. I just want to, and I made the decision on the wheelchair at seat elevation with the Mason team. I just want to give a piece of advice of your an invitation. Giving too much information to CMS, we have different requirements than FDA. And it was based on strategy. And I'm happy to talk at the meeting, but I think the Item Coalition brought to us a 1,000-page document. It was not up. We found in that 1,000 pages something about shoulder dystocia and shoulder strength that allowed us to do something and actually improve that seat elevation. So I'm happy to talk later, but I just thought this was really important group here that we giving too much information that doesn't talk about medical outcomes will not be the benefit. I know CMS hasn't been able to come to these. May not be the benefit of really achieving the goals, which is anticipation, show medical benefit. Thank you. No, thank you and good to see you. I'm glad that you're joining us today. That is exactly the kind of message that we want to hear. I will note, with thanks to Vivek and Dujani, that a year ago, I will speak for the crowd. I won't be exactly right for everybody, but we couldn't talk about concepts of interest and contexts of use at all. These were not familiar terms to many of the people in this room a year and a half ago, but it's thanks to FDA. It is thanks to some of the interactions that we've had with colleagues with CMS that we're beginning to understand what these mean and how these terms are going to be applied to our field so that we can begin to create meaningful outcomes and design clinical trials and eventually present something that I will now take the liberty of promising will not be a 1,000-page document that this group presents to CMS in the future. But it's really a key message, and so thank you. We're making good progress here. All right. So next, I'm going to invite up both Dan and Dan. Yes, good. Okay, good. Dan Rubin, who's going to be telling us a little bit about the clinical practice guidelines, and we will have the opportunity to come back to talk about some of the important points we just heard.
Hello, everybody. Hi, I'm Dan Rubin, Mass General, and I'm the co-lead of the Clinical Practice Guidelines Working Group. And I'm going to bet it's this one. It sure is. Great. So what is the Clinical Practice Guidelines Working Group? What have we been doing? So our goals from the outset have been to establish consensus around the best practices for implementation of iBCIs, to, as a work group, understand what are the questions that need additional research before we can reach some consensus. And then ultimately, the big goal of this working group was to develop and ultimately maintain a clinical practice guideline that will be a resource for clinicians, researchers, industry, folks who want to work in the iBCI space. We've had an incredibly productive year. It's been really exciting to work with a really robust multidisciplinary team with an international basis. We've got researchers, clinicians, people with lived experience, people from industry, academia, regulatory fields, all coming together. And we're incredibly grateful for the incredible amount of time and effort that all of these people volunteered to help this working group move forward. So what have we done? Well, we've had a pretty productive year. Like the other working groups, we really sort of started in earnest at this meeting last year at Silver Springs, where as a group, we set the goal over our first year of understanding what are the clinical practices that are actually used to date with iBCIs, understanding what those have been, reviewing those, and then putting them into the context of a hypothetical patient journey so we can begin to understand how to develop a formal clinical practice guideline. And I'll tell you a little bit more about that in just a moment. So we came together at this first meeting last year. We created a list of topics that we wanted to review. And then over subsequent monthly virtual meetings, we delegated those topics to individual work group members. Work group members performed focused literature reviews. We came together, we compiled all of those literature reviews into a draft white paper. We spent a couple of months going through that white paper together, cobbling it together, seeing what fit, what didn't fit, having discussions about what was in scope, what was out of scope, where was there enough data to say something meaningful, where was there not, and we just had to sort of leave it to the side for a little bit. And then in April of this year, we had the opportunity to present the first draft of this work at the annual meeting of the American Society of Neuroradiology, not the Society of Neurology, Society of Neurorehabilitation. The websites get me mixed up. So at ASNR, Neurorehabilitation, we hosted a workshop on building clinical practice guidelines for implantable brain-computer interfaces, and very appropriately titled. Many of you who are here today were at that workshop, and thank you. Incredibly productive. We had a 3-hour-long workshop where we presented the draft of the white paper. We went through it section by section, and in each section highlighted key questions that had come up for debate in our individual working group meetings, and then posed them to this larger group of experts. We solicited a ton of feedback. We got all sorts of great thoughts, opinions, things we hadn't thought about, things that we had thought about differently than we should have been thinking about them. We brought all of that feedback together. We went back to the working group over the summer. We iterated and included that feedback into the manuscript, and we have recently delivered that to the leadership of the iBCI-CC for final review. And our hope is to submit this for publication in a peer-reviewed journal in the coming weeks. So I want to just give you a quick overview of what this white paper looks like, and you can tell it's a real white paper because I think it even still has it still has grammatical error in the screenshot, so you know it's a real document. So like I said, we broke it up into sections based on a hypothetical patient journey, going from pre-injury diagnosis to referral, then pre-implantation questions, implantation, short-term use, long-term use, and then other things that didn't really fit into a chronological organization. And we framed it as a series of questions, much like a clinical practice guideline might be phrased. You know, how do you approach these different questions? And these are just some examples. I'm not going to go through all of these in detail, but you know, when it comes to from injury or diagnosis to referral, things like what conditions are most likely to benefit and what characteristics have been used in trials to date, how do the existing capabilities of assistive technology impact the way we think about referring someone for iBCI, how do individuals become candidates for iBCIs, what sort of subspecialty interactions are necessary. When it comes to pre-implantation, there were a lot of really great questions that came up, things like functional assessments that should be performed, what sort of imaging needs to be done, how do we integrate users' priorities and preferences into making decisions about implanting a BCI. And a lot of these questions, as we'll see in the coming year, are perfect opportunities, in addition to the literature review we've done, to collaborate with other working groups, because there's a lot of other working groups that are focusing in even greater detail on a lot of these questions. When it came to implantations, things like surgical and other factors, after implantation, what are the sort of key elements for immediate postoperative care, calibration, system performance assessments, and then in the long term, things like how do we support users, both in terms of their well-being, as well as what medical subspecialties and other interactions need to occur over the long term to ensure that people are successful, and what challenges do caregivers face. And then, again, some other things, in particular, things like what sort of standards of evidence should we begin thinking about as we move from a review of clinical practices to a formal clinical practice guideline. So that was a lot really quick. Where are we going from here? So this afternoon, we'll have a breakout session. We're going to map out the goals for the coming year, like in all the other breakout sessions. Our hope is to take a deeper dive into a couple of the key points that I brought up, areas that we identified as rich with a deeper literature that we can review and learn more about. We want to spend a decent amount of time planning out the next step. So we've got this review. We're rather proud of it. We think that it covers a lot of important topics, but we recognize that it's a review of things that have been done. What do we need to go operationally? What sort of experts do we need to engage? What sort of human and digital infrastructure do we need to establish so that we can move from this review to an actual formal clinical practice guideline? And then we want to begin outlining what we think are some of the core components of centers that are going to be placing iBCI. So as this technology becomes more widespread and becomes available in greater number of centers, what are the sort of things that we're going to suggest that centers be capable of having? What resources are they going to have so that they can adhere to what we are hoping to lay out as the best practices? And that's everything we've been up to.
Thanks, Dan. I will point out that in this work group, thinking about clinical practice guidelines, or more proximally, just exactly what should clinical practice look like. When we think about some other implanted neurologic medical devices, think about deep brain stimulators, for example, for the treatment of Parkinson's disease. People early on in developing that movement disorder may see their PCP, and then they eventually see a neurologist. That's kind of a known step for somebody who has a movement disorder. They generally would receive some sort of dopaminergic agonist or other medical treatment, medicine treatment for that movement disorder. And then eventually, if it's appropriate, they would be directed to have an interaction, often with an interdisciplinary group involving a neurosurgeon, who might then collectively lead to recommending the placement of a deep brain stimulator. That is known, and that kind of clinical pathway has been established now over 2 decades. For what, as everybody in this room recognizes, it's really hard to draw that path today. It's even if we were to kind of draw the lines between different people, between different clinicians who may interact with a patient that is a person with lived experience of paralysis, whether stroke, spinal cord injury, ALS, or other disorder. We don't have that pathway. We're nearly starting at tabula rasa, and so with Dan, with Ben, and the rest of the work group, I think it's great just how much progress you've made. So congratulations. With that. And with a little bit of a hint and a teaser, we're now going to move on to this incredibly important topic of payer interactions and device categorization. And I will hand right over to Kurt. There's Kurt. There.
Thank you, Lee. Appreciate it. And thanks to everyone, obviously, that cares about this space and industry for coming here today. Before I get kicked off, Dr. Tarver's talk this morning, I hope we get a recording of that, because I actually think and I want to listen to it over again. I think it was probably one of the most concise speeches in where we go, what it means to the patient, the autonomy, the independence, and what these type of technologies can deliver for individuals that are out there that have lost that independence. And so that was an amazing talk. So I'm Kurt Hagstrom. I'm the Chief Commercial Officer at Synchron. I'm the co-lead for the Payer Interactions Group with Jamie Strauss. Unfortunately, she wasn't able to be here today. I think maybe in the case. So again, progressing the field forward, which is great. Our vision in this group is to ensure implantable BCIs are clinically effective. Of course, that's collaborating with other groups, economically viable, and broadly reimbursed. Our strategic objectives, are to demonstrate the value through evidence, both clinical and economic outcomes, establish reimbursement pathways. What is the benefit category for these implantable BCIs? What does coding look like? Align regulatory and policy strategies. So bringing key stakeholders, and we'll do that in our breakout session this afternoon, from FDA, CMS especially, and what are the levers within that group to be able to bring a technology like this to market. And lastly, to engage and educate stakeholders. So once we develop the evidence, once we have this, is really start to understand where are patients seeing the benefit, where are caregivers seeing the benefit, where is the community seeing benefit in these technologies, and make sure we have that open conversation all the time. And I actually think that the collaborative community is an amazing place to keep that education process going. So over the last year, I think we probably had about 4 or 5 meetings But I think we delivered some big things. So first, developed an outline in the white paper around the cost considerations and cost economic impact of these BCIs. We completed a reimbursement survey with the working group, and we're able to publish those results. We also had, I think, a key Q&A session with TJ Selpin at CMS. So we were able to basically pose all the questions that the group wanted. And then he, I think, did an amazing job to answer as best he could all the questions. And so we have that published. And then lastly is really the foundation, I think, of us moving forward. We drafted a 3-year strategic plan. And so I think that's key for us to say, okay, what is our next steps? Let's not take on too much, but let's see what our next steps are. And I think we've gotten a lot of great input from the working group on that document. So thank you. So what does that roadmap look like? Phase 1, we're looking at building a foundation of from literature review, stakeholder mapping. We're going to tackle that this afternoon. Value proposition workshop later this year. We also then want to start to collect the evidence, look at health economic models, cost effectiveness. We want to understand eventually getting to that benefit category and mapping what are some other benchmarks that we can pull from. And lastly, in phase 3, what is that policy engagement and what do those deliverables look like from a coverage proposal package? So, right. So we're going to eventually have to try to get coverage, and that's going to be a packet that we're going to have to put together for that. So as much as possible as a group, what can we deliver to that's going to be fundamental for all industry partners? Then understand again from public publications and white papers, again, delivering the evidence that is going to be needed for coverage on these products. So this is how it breaks out from a timing standpoint. We're going to produce a stakeholder insight report. We're going to kick off a value proposition. This probably will go into maybe more Q4. We want to publish and do a lit search around the reimbursement and health outcomes. Then we want to get to a benefit category analysis early next year, an economic model thereafter, and then start to work on that policy advocacy plan in Q3 and Q4. So I think we have a lot here. And I hope everybody can come to the session. I don't know which one you're going to, but I'm a little biased if you can come to our session. We need a lot of help, and we need a lot of participation. So here's a little bit about what we're going to be talking about this afternoon. We're going to go a little bit deeper in the plan. Dr. Lee Fleischer, thank you, Lee, for speaking. And I think it's key bringing that voice into this discussion as well, really grounding us from both clinical and efficacy, but also what's medically necessary, right, and what's out there. So we have to bring those voices together in the room. And Dr. Malvina, I think, is also going to join us as well. So pretty critical that we bring the key stakeholders and extract their voice. So thank you guys so much. Really appreciate the support and look forward to the conversations this afternoon.
All right, thanks so much. As again, many people in this room know, this really is a collaborative community. There's expertise in science, there's expertise in medicine, there's expertise in medical device development and medical device regulation and ethics and in any number of key aspects and of course in lived experience of neurologic disease and injury. There isn't a whole lot of expertise at the outset in thinking about payer interactions and Kurt, wherever you just went. Thank you for just updating us on the great, there you are, on the great progress that the work group is making and helping to kind of set the ground level of our collective understanding and helping us to move forward. So with that, and seeing Rob, we're going to move on to talk about modular components, interoperability, and other standards. Really a highly technical, but also highly important topic because of the potential power of these devices that is implantable BCIs to be connected with so many other devices that would be helpful for people with neurologic disease and injury. And I will hand over to Rob.
Thanks, Lee. So really proud of the great work that's been going on in all the other working groups. Our group is quite a bit more technical than the other groups. It's not trying to cast shade on anyone, but we're focused really on how do we build these devices and encourage manufacturers to build modularity into their devices so that people could come in and build components that work with third parties can build components that work with these devices, as well as thinking about how do we encourage standards organizations to write standards that help us to test the devices in a coherent way so that every manufacturer can test their devices in the same way, and think about how do we standardize how we do some of the things within the iBCI-CC. We think it'll improve patient outcomes by allowing for more innovation so we get new innovative solutions, as well as speeding up commercialization because manufacturers have clear pathways on how they test their devices, how they bring their devices to market. So the first project that we've been working on this past year is building a review of all of the current standards and medical device standards that apply to implantable BCI devices. We've made the standards list, and then we've gone through that standards list to look for any gaps. Where are there places that testing is written that may not apply to all of the iBCIs? Where are there places that we could improve or maybe increase the level of rigor that's been placed in some of those standards? And so now that we've got the gaps identified, we're creating a list of actionable items and thinking about how we're going to approach that. Are we going to update standards? Are we going to write new standards? Are we going to publish guidance on how manufacturers should think about those standards? The next project is building a system model of implantable BCIs. We've built that using the object process methodology. That model has been done and written up. We're currently working on getting that published through the iBCI-CC leadership. That should be going out for review. We've done a first review on it already and addressed some of the comments and concerns from that. Next one is lessons learned from other fields. This one was a little bit different, but I think also still important. The idea here was we had a portion of our working group go out and look at really they looked at MDUFA and not MDUFA, but some of the medical databases, and looked at where have other devices fallen short or failed, where have there been failures shortly after launch of these devices, especially in new categories and new areas. And so they put together a bit of a lessons learned document. We're reformatting that as a white paper so that it's a bit more digestible from the raw data format that we originally had it in, and plan to push that out to all the medical devices manufacturers so that way they can look at these and just make sure they're thinking through some of the places that other companies have struggled. And then the last project is a standard data interface format. We've been looking at how to share data between different manufacturers' devices and make those data publishable and more easily relatable for different groups so that academic groups can collaborate more easily with companies, and users have better ways and tools that can be developed to look at their own data. We've looked at a bunch of different candidate file formats. Right now, the leading file format is the Neural Data Without Borders format. We're going to craft a policy statement. That's part of our workshop today, is looking at that policy statement and how do we want to state that and push that out. And the next thing will be to go and start talking to the different manufacturers and talk with them about the Neural Data Without Borders format and see if there's any concerns or problems to getting that implemented, so that we have a universal file format that data can always be published from different manufacturers as we push things out. So upcoming priorities for this year, we're just going to finish working on getting our first set of outputs done. We'll have an approach for how do we push the Neural Data Without Borders format out, and then prioritize more component interoperability across BCI devices. That's it.
Rob, that was great. I think I'm going to guess that as we saw some of those bullet points up there and some of the plans and some of the potential outputs from that work group, there may have been some people in the room, perhaps affiliated with one of the startup or medical device companies, saying, "Are we really going to do that?" And wait a second, I want some input into that. That is exactly the reason why we're here. It's one of the reasons that we are a collaborative community. We're here in this pre-competitive space, being able to propose things that would actually be able to unify some of our approach as a community and across the different medical device companies that are represented here. So I was really excited to see that. And with that, I will be handing off, I see Chloe, who's going to be telling us about public messaging, BCI education, which is so important for the community, and our regulatory science education.
Good morning, everyone. My name's Chloe Brown. I work with Synchron from a marketing perspective, so this is a little bit of a different perspective than what we've heard this morning so far. I'm here on behalf of Alana, who is just sitting over here. Hi, Alana. And also Abby Sawyer, who unfortunately can't be here today with us. So our work group is a little bit different, but we're really trying to be that communication piece for all of the work that's happening within the collaborative community. And really, public understanding and acceptance of iBCIs is going to be critical to the technology's widespread adoption. We're motivated by the need to develop a coherent and effective framework for communicating the benefits, risks, and ethical considerations of iBCIs to the public. We know that educating the public is essential, and it's quite challenging to take these really difficult concepts and get them out into the lay person's language and enable people to understand it. We want to build trust within the community. We want to address any misconceptions that are out there, and we know there's lots, and just to try and build that trust. We seek to fill the gap in public knowledge and educate a variety of audiences. There are many different audiences, from the patients, the caregivers, the advocates, the CMS, the government, the clinicians, the new technology people within the hospitals, financiers, the number of people that we need to educate over the course of the next however many years is very broad. And the messages associated to that are completely different. So we really need to work on that. And why is this work so important? If you look at the public literature that's out there, the access from the media to, or the excitement within the media, general media and tech media, over the last 3 years, you can see it's quite broad in the types of media that is picking up BCIs. And I did a very quick search. I'm sure there's a lot more, but you can see it's grown massively from, just under 2,500 stories that are talking about BCIs, up over 3,000 already this year. And the other thing we can look at is the change in the key messages, the key themes that are coming from this media, the stories that are out there. Research and ethics in 2023. In 2024, there was much bigger impact from the first-in-human studies and safety, thanks to the Neuralink trials, really. And this year we've seen, scaling, standards, reimbursement, just like we've just been talking about. So it's really front of mind, even in the media. So we want to make sure that we can't control those stories and those messages. So we need to make sure that we are educating the community that matters to us in a way that is, as I said, ethical, answering those questions, making sure that people believe and trust in iBCI. So from the perspective of progress over the last year, we have created an iBCI-CC informational video. So I'm going to actually play that for everyone so you can see what's going to go up on the website when it's finished. It's in draft. We also took some time to map the audiences, like I just talked about, and develop key messages that are across all those audiences. And the next stage with that will be to create almost like a messaging matrix to make sure that we are addressing all those key messages to the right audience in the right language. We had some input on the iBCI-CC website with the About Us page and the frequently asked questions. And that will be an ongoing project, I think, for this group. As Jessica already mentioned, the community group education with some webinars and some presentations, and that will be a key part of the ongoing work for this group. And we also understand the need for understanding what's out there in the public domain, what are people saying online in various groups? So we're starting to try and think of a strategy to deal with how do we screen those online platforms and understand and potentially combat any negative comments out there. I don't know if this is going to play. Do I have to press something special?
Implantable brain-computer interfaces, or iBCIs, are devices designed to restore mobility or communication for people with neurologic disease or injury. Specifically, iBCIs record from the nervous system using a sensor placed in or on the brain, interpret that neural activity in real time, and do something useful with that information. For example, allowing a person with cervical spinal cord injury to control a cursor on a computer screen simply by thinking about the movement of their own hand. These technologies could have a tremendous impact in enabling the independence of people with severe speech or motor impairments. However, the journey to iBCIs becoming widely available faces regulatory, ethical, and commercial challenges. These challenges need to be addressed in a collaborative forum of knowledgeable stakeholders who offer a diversity of perspectives and experience. And this is where the iBCI-CC comes in. The Implantable Brain-Computer Interface Collaborative Community, or iBCI-CC, is made up of a diverse group of iBCI stakeholders, including researchers, industry leaders, healthcare providers, regulators, patient advocates, people with lived experience, and care partners. Collaborative communities are grassroots organizations focused on achieving shared goals, advancing scientific knowledge, and sparking innovation in medical device development. Collaborative communities, including the iBCI-CC, possess the unique ability to host meetings in what is called a pre-competitive space. In short form, this means that companies striving to design new technologies can work together openly and transparently, in collaboration with people from federal agencies, to discuss common challenges and seek consensus toward potential solutions. At the iBCI-CC, we aim to accelerate the development and commercialization of implantable brain-computer interfaces. We are focused on incorporating feedback from many stakeholders to build consensus and spur action around key iBCI issues. Our work is organized into several specialized work groups, each tackling essential components of iBCI commercialization, including identifying user priorities, preferences, and iBCI use cases, defining clinical study endpoints, establishing clinical practice guidelines, interacting with payers and defining device categories, exploring industry standards, modularity, and interoperability, engaging with topics on ethics, neural data privacy, and data security, and finally, disseminating public messaging and education around BCIs and regulatory science. Each work group generates projects, reports, presentations, and tools that we make publicly available, sharing valuable insights with the broader community. To stay informed on our progress and learn how to join our collaborative effort, please visit us at ibci-cc.org.
Thank you to Jessica for putting that together with some of our team members from the working group. I think it's going to be great to have that on the website and really explain in simple terms what we're trying to do and where we're going to go. So I thought I'd go into a few of these key talking points and just get everyone's brains thinking, ready for our workshop this afternoon as well. Thinking through those key talking points are also important across all the working groups. So, we're created for people, guided by people, making sure that we've got patient voices at the center of what we're doing here. Giving a voice to the voiceless, the human impact and patient stories again, building the future together, so collaboration across stakeholders, writing the rules early, like we're going to talk about in a minute with safety and ethics from the start, solving tomorrow's challenges today, being proactive, your brain, your data, protecting neural privacy, from breakthrough to access, making tech affordable and equitable, nurturing independence, enabling fuller, freer lives, first of its kind alliance with FDA and community partnership, and delivering tangible solutions, real outcomes, not just discussion. And I think from what I've heard already today, I think there are real outcomes coming from this group, which is just so great. For 2026, our top priorities are going to be to further build out the key messages by the audience, to continue to build educational tools and opportunities for education and for learning with the community groups and all stakeholders, and provide a platform for the information and experience sharing within the community interested in BCI. We will be creating a communication strategy that will really take us through that journey. And what we're thinking of is transitioning a little bit from what is a BCI into more of what is the benefit going to be, and trying to hone in on that CMS, the CMS language as well. So patient need, clinical benefit, economic impact, and alleviating caregiver burden. As for, there's a lot more messages, obviously, that we're going to workshop. But thank you, everyone, for joining. And I look forward to seeing you all this afternoon, helping me work through this.
Oh, who's here? Okay, perfect. Who's here? Where's on? Yes, come on. Okay, good. Thank you, Chloe. Such an important goal to be able to communicate what everybody in this room knows so well to a much broader group of stakeholders and folks who are interested in understanding this field. I was just asking if somebody was online, but you're actually here in person, so that's great. So. Oh, and Michael is also online. All right, so it wasn't an hallucination. That's good. So I believe our last work group to present today, I'm looking for confirmation, yes, is going to be on a topic that has been hot again recently and really has been pivotal since since Planet BCI started being discussed so many years ago, which is that about ethics, neural data privacy, and data security. I think some of you may have heard Marcy Wilder provide that just incredible 101 on HIPAA and neural data, which was part of our Foundation's webinar on Wednesday. We're all looking forward to 201 and to 1220 and to learning more and more about the existing legal structures for thinking about neural data. But of course, our laws reflect our ethics, and we've got a great group that's been thinking about ethics and neural data privacy in this field, and I will hand over to Kamal.
Good morning, everyone. My name is Komal Kampasi, and I co-lead the Ethics, Neural Data Privacy, and Data Security Work Group with Michael Young, and I'm with BlackRock Neurotechnologies. My background is in microfabrication and system design, and over the course of my career, I have been incredibly fortunate to work with some of the best BCI teams, and I do think that has given me a very front row perspective on the exceptional talent in the field and also the very important responsibilities that come along with it, which is why I'm here. So as I lead this work group with Michael, who's really the expert amongst us on neuroethics, our collective effort on this work group is to advance ethical standards and framework for very secure and equitable use of implantable BCIs. Since the inception of the work group, we have had these 3 flagship projects, which are as displayed here. And we are excited to share today that all of them are towards the very end of their completion stages. So in today's presentation, we'll walk you over through how these projects have evolved over time, what we have learned from them, and how we also think they could contribute being a very valuable resource to the community. So starting off with a clinical iBCI ethics gap analysis project. So how this project came into being is as a collective effort where our group, as a work group, we realized that there are ethical risks in iBCIs that remain unexplored. And as our discussions went on, our purpose was to really identify the gaps in engineering, in guidance, regulation, responsibilities that exist across the whole iBCI life cycle. So as our discussions progressed, we thought it would be most useful to put our perspectives and very rich discussions together into a mixed methods gap analysis paper, which is what eventually formed the scope of the manuscript draft that we've been working towards. This slide shows the structure of how we got together all that data and put that into a paper. What you see on a slide is a very oversimplified schematic of an implantable BCI. You see an implant that collects neural data and that passes on to a decoder, eventually into an effector. And the surrounding boxes there indicate the cross-cutting ethical domains that we identify are the most critical ones, requiring standards and safeguards throughout the translation of this technology from research to clinical use. As we go deeper into each of those 8 ethical domains that I just showed on the slide, we also categorize them across 3 stages of the iBCI's life cycle, which is pre-implantation. That's everything that happens before even the patient gets implanted and what ethical concerns and safeguards can be put in place then. Then go to the stage of implantation, which is mostly surgical implantation and the immediate post-op that follows. And then finally into post-implantation stage, which is the final stage where the implant stays into the patient for many, many years and what guidelines and ethics need to be followed during those stages. For the convenience of the reader, we have really organized all these gaps, concerns, and also provided recommended solutions to cover those gaps in a table format in that paper so that it's easily readable and also very accessible to somebody who's trying to implement these as we move forward, as they try to implement these practices into their work. In addition, what we also show is a global landscape of how these clinical trials for neurotechnologies exist worldwide. We do acknowledge the fact that even though for most of our discussions, what we do in the US does form the center part of it, there are many parts in the world that are not as, which are even further behind in terms of when we think about affordability, access, regulatory access. So it's very important to identify that how these geographical, cultural, and societal factors would impact and shape the future of the ethical standards for the iBCIs. So in the summary, I would say this project it provides a blueprint to ensure that iBCI users are safe, they're respected, they're safeguarded. As a deliverable, in our knowledge, this is the very first field-wide framework provided on the subject from a very broad stakeholder community, which included clinicians, engineers, researchers, industry people, regulatory bodies, and even the perspectives of the participants themselves. So this all really came together as a very rich perspective on the subject. As far as the stage is concerned, it's currently undergoing organizers' review, and we hope that we'll be able to publish it soon through a publication house so that the resource does become available to every one of you for reference. With that, I'll hand it over to Michael to talk about the other 2 projects.
Thank you, Kamal.
Thank you.
A second and intertwined initiative of our work group is focused on optimizing informed consent to reflect the unique risks, uncertainties, and long-term realities of iBCIs as they move toward clinical use. And as part of these efforts, we're developing an iBCI informed consent checklist. And this is a tool that's designed to support researchers, clinicians, and local IRBs as iBCIs move from investigational use into broader clinical integration. Next slide. Organized across pre-implantation, implantation, and post-implantation phases, the checklist addresses key issues that may not be fully captured by traditional informed consent guidance. This includes communicative capacity, decoupling surgery, device, and data risks, neural data interoperability, ownership and portability, post-implantation feature updates, and capacity shifts as people progress in their journey with an iBCI. In this project, we also highlight potential implementation strategies along with limitations and priority areas for empirical study. Next slide. We're in the process of finalizing this checklist and accompanying manuscript. We plan to submit this for publication as a resource for the community in the next several weeks. And once available, it will be made available on our Neuroethics Resource Hub. Next slide. Next slide. As part of these efforts as a work group, we've developed a hub to serve as a centralized home for neuroethics resources built to empower clinicians, developers, regulators, and other community partners that are navigating this evolving ethical terrain of iBCIs. Next slide. In addition to serving as the home for our work group's outputs, this undertaking really was animated by a broader realization that existing resources, informative as they may be, remain somewhat fragmented and often disconnected from practitioners. And so this Neuroethics Resource Hub came together as an effort to address this gap by creating a centralized living compendium open to ongoing updates and contributions through user suggestions, helping clinicians, researchers, policymakers, and other community members easily find what they need to support the responsible development and deployment of iBCIs. Next slide. Each of you can now explore the Neuroethics Resource Hub at www.nerh.org, neuroethicsresourcehub.org, and it brings together over 100 resources, policies, regulations, white papers, and videos. And there should be an embedded video on this slide, if you can click, that demonstrates that how resources which were once scattered across many places are now brought together in this unified resource hub that's easily searchable, filterable in one spot. The hub is designed to evolve with the field, so users can suggest new resources, keeping the hub current and relevant. And each month, we hope to feature a ethics resource of the month that highlights emerging ideas and best practices. And looking ahead, the Neuroethics Resource Hub is really designed to be a dynamic platform which could eventually host empirical neuroethics data sets that will guide the field's future. Next slide. Next slide. So we have many really profound questions and opportunities ahead of us. And today we'll focus on particular questions surrounding neural data security and privacy, decoding intended versus unintended outputs, and questions of neural data ownership. Next slide. If you're interested in learning more or joining our efforts, Kamal and I would be thrilled to welcome you. And as we grow this community together, all of this work is only made possible through the kind of multidisciplinary exchange and collaboration that's been so amazingly enabled by the collaborative community. And we are so grateful to the organizers and sponsors for making this work possible. Thanks, and looking forward.
All right, thanks, Kamal and Michael. Michael, I know you can hear us online. We at some point we decided that we knew what you looked like, and we made the screen nice and big here in the room so that everybody can see the Neuroethics Research Hub that you and the group have so wonderfully put together. So with that, and 5 minutes ahead of time. So credit to the work groups for your great presentations. We will now take a still 15-minute break to get us to 10:20. So please take a moment. Restrooms are around the corner to our right. There should be coffee and other things out there. We'll see everybody back here in the room and online in 15 minutes, 10:20 Eastern. Thanks. All right, come on back in. Good to see you all. Hope you're able to get some coffee, and it's so nice to see the rapid interaction. So I tried to get people back in the room. I was given dirty looks saying, but this is why we're here, to see. You'll have more of a chance. All right. So in a moment, I will introduce our next speaker, but I do want to recognize and as many people both here and online recognize, we are the first FDA participating collaborative community in the clinical neurosciences, that is in neurology and neurosurgery. Kind of have to slice and dice that comment to get it quite right. And we're incredibly proud of that. We couldn't be more grateful that there are so many folks from CDRH and from OHD5 who are here in the room today. This is where I kind of say out loud as a reminder that the FDA staff and others who are here today are here as participants just like everybody else. They are here to help, as we all are, to think out loud, to ask questions of each other, to learn collectively, and to help move this field forward. They are not here, and you should not ask them to provide guidance on specific questions. So if you've got a specific question for your device and you want the answer, not today. But we will collectively try to get there. And so with that in mind, we will now hear from a person who you can ask anything you want, just don't ask for a decision today. A real pleasure to introduce David McMullen, who of course is the director of ONPMD. So with that, David.
Hi, good morning, everyone. Hope you're having a great day. It's lovely, nice weather here in Baltimore. It's great to be back. So building on Dr. Tarver's talk, I really want to emphasize that at FDA, we really do believe in our mission to both promote and protect the public health. And I bolded promote here, that is the point of our involvement in the BCI collaborative community, but it's also a collaborative effort. So I also saw that video for the first time today, and I assume that as regulatory was said and a hand was coming in the frame, that the next frame was going to be it reaching out to shake hands and to emphasize that we do want to work collaboratively with you. We do, establish some guardrails, put out guidelines, but we really are committed to promoting public health. As part of that, it takes people. You can't just say that. So I have 2 points for this slide. So one, do want to highlight there have been some changes. Vivek has left the FDA at this point, and Jay Gupta and Heather Dean in the back have now taken on the mantle for acting division directors. So Heather previously more directly led the acute injury team, where the vast majority of BCI work is located and housed at FDA. So just want to ensure that you're all aware of that. But also, more importantly, are the folks not named here. So could we have the FDA folks in the audience stand up? I would love everyone to be able to see our great staff. These are the people, including our TAP colleagues. Yes, you as well. These are the people promoting public health. And to underscore that commitment, I just wanted to highlight, everyone here from FDA, they pay for their way here. They are committed to being here, whether it was by train, by plane, by automobile, by their feet walking here. Everyone here is really committed to the mission of the BCI collaborative community. And so just wanted to highlight that. But the other part of that is really you all here in the collaborative community. We're not going to be developing the devices. We're not testing them in patients. That is what you are all doing as device developers, as clinical researchers, patients who are volunteering for this. You're all doing that work. We're just here to work with you. Dr. Tarver highlighted the total product lifecycle. And I just wanted to really dive into that because implantable brain-computer interface was doing some amazing innovation over the past decade, but we really hope the goal, the motivation, and what we see the implantable brain-computer interface collaborative community doing is to enable that last step of true translation to patients. We're still here. We're still here to promote that innovation. So want to highlight the Breakthrough Devices Program. Again, most of you are well aware of this. You may have one or more of these breakthroughs under your belt, but for you, some of you with newer companies or with program, which really can provide funding for some of that early translational work. We also have Dr. John Nye here, director of the Brain Initiative, that has also funded so much of this work and joined by other colleagues in the audience as well. So for those of you clinical researchers, this front table is where you want to direct your attention. Yeah, no decisions, but they can point you to funding opportunities. Speaking of working together across the government, I want to highlight a workshop that many of you attended and participated in, and really to underscore the NIH and FDA's strong interest in developing these clinical outcome assessments, which is, a critical component of doing a benefit risk determination when you submit marketing submissions. FDA also does have a little bit of funding. As I've said before, if you want to build your career, you should be looking for NIH funding. But if there are targeted efforts, the FDA does provide through a BAA broad agency announcement, as well as specific funding through some endeavors such as the Act for ALS, which some of the members in the audience received some funding for as well. So for those who are developing regulatory science type efforts that might not fall under traditional NIH funding mechanisms, please come talk to us. Keep an eye out for the BAA. If you're developing a clinical outcome assessment, things that are really critical for that implementation and translation of devices, FDA does have some funding. Now, we had a prior CMS colleague in the audience, and great to see that he'll be speaking later. But if you are looking at the entire journey for your device, you will need to get it paid for, and you should be well aware of the TCEP program. The working group has talked a lot about this, but please familiarize yourself with this and understand the timelines involved, because this is translational coverage for emerging technology. Understand what the coverage analysis group is, what CCSQ are. They're going to be partners as well in this journey. Again, CMS is also thinking about innovative pathways. We know that BCI is such a brand new medical device. As Lee's highlighted, what is the care model? We don't even know the referral pathway. We're all figuring this out. There might be 10 different clinical specialties in the audience represented today. How do we get that to work? And so CMS and others are thinking about how do we think through innovative care models when there are new, potentially expensive, hard to reach types of diseases and therapies. But like I said before, in order to promote the public health, it's going to take all of you in this collaborative community. So want to take a second to acknowledge all the great work the working groups have done, all the success to date, and really to motivate some of the work going forward. Just to highlight some screen grabs of recent research. BCI is not a static field. New questions will come up as new research is out there. So I'm sure some of you are well aware of the inner speech work that's been going on. Great that there's a working group focused on neural data privacy and informed consent. So what that means will continue to shift and evolve. And what are end effectors? Rob is going to figure out the modularity for driverless cars and how BCIs can do that. So good to see groups working on that. But even, I come from CDRH, the representatives here are from the device side. We know that there are various neuroprosthetics that might also interface with biology in different ways. It could be optogenetics, different gene therapies. So at FDA, we do have folks involved in biologics as well. So let's talk. And as sort of that future vision is coming together, I really see a role for the iBCI-CC in trying to navigate. Again, patients are at the heart of what we do. I love this graphic because I think it really underscores the real innovation in neuroprosthetics. I mean, just on this one thing, I didn't create this. I would have put even more neuroprosthetics, but you have a retinal visual prosthetics, you have a modular prosthetic limb. It just really underscoring how much innovation you are all driving forward. So one last note, we are hiring. We are hiring from engineers for biologists. I did hear a little bit of a hush there, but please come talk to us. As you can see, the work at FDA is so critically important. If you are a clinician in the audience, we are hiring neurologists, neurosurgeons, physiatrists, psychiatrists, and the work you do really does protect and promote the public health. So if you're all aware of anybody or you yourself are interested in a new career, please come talk to any of us to get different perspectives as well. All right, thank you.
David, what was the link for the neurologist hiring? Just to reiterate, we as people in the room know there is an amazing team at FDA who is helping to think about these devices at every moment. So for those in the room or online, just to reiterate, if you are interested, that job posting and those job postings David just mentioned, if of interest, please do look into them. It's a great team that you would be joining. So with that, I think we are now at our Q&A. Looking at Jen and Jessica, anything you want to whisper in my ear? No, we'll keep going. Okay, good. As part of being a collaborative community, we have an annual public meeting, and it's an opportunity to ask questions. Most of us will try to provide answers as best we can. We already talked about the ones that won't get absolutely, definitive answers that you would consider to be guidance in any way. But we're here to either ask questions of each other or to ask questions of the co-organizers. That is of the four of us that are around. There's a microphone here. There's a microphone in Joe's hand, which he can bring over. There is online the Q&A box. Looking at Jessica, that's true, and you've got access to that box. Great. So if you're online and you have questions, then we'll be able to read those aloud in here, which we will do confidentially, or we're going to say who's or not.
We're going to read the names.
We're going to read the names out loud. So that's not confidential. Not confidential in the room won't be if you put it in the box. That has been asked before, which is why I'm saying it out loud. So with that, we are here to answer questions about the collaborative community, past, present, or future. Please raise your hand if you're in the room, you'd like to ask any questions, or if you're online, please put one into the Q&A box. There we go. We've got two over here. Yes.
Hey, thank you. So this is Misha Sarui. I'm from Jefferson Raphael Neurorestoration. So I think this is a good question to pose to a care collaborative, which is, and I'm not asking for any FDA decisions. My team works on assistive devices, not implantable. And so I have a question, and again, is this a role of a care collaborative of trying to understand what's sort of the regulatory pathway or how to think about it and which all these work groups where it would be inserted. Most of these discussions have been obviously about the eye, the implant. The question is for my team and others who may not be represented here, who are making non-implantable devices, such as different new kinds of powered wheelchairs, prosthetics, orthotics, that we want to work with those implants. What's sort of the right way to engage this community so that they can make progress? So for example, I wouldn't want to have to make I wouldn't want the FDA to say, you have to try it with every single one of the iBCI vendors in order for a patient to use it. So I'm trying to use my example of my team as sort of a case example of like, how can we think about how to work with the CC to sort of map that out so that as a team that's developing a technology like that we think could one day help people with paralysis so that it can connect to whatever is eventually approved in the coming years. Does that make sense?
Yeah, absolutely. Thanks, Misha. So I should look. All right. So two thoughts. One is that the eye is up there, in part on purpose because we needed to decide roughly what the boundaries would be of the collaborative community as we got going. Those boundaries may shift a little bit over time, but largely we are, just as you pointed out, focused on implantable brain-computer interfaces. Having said that, you also correctly noted out loud that these devices will be connected to things that are not implanted. And Rob Franklin, I saw you just before, who presented, thanks Rob, about the modularity work group looking at standards and how do the devices that are implanted connect to anything that is not implanted. And I think that one work group would probably be the best place to interface to get their feedback. They are thinking about those connections, both from a technical standpoint and more generally, how are these devices, when they're at the most powerful, re-enabling the control over, for example, consumer-grade communication devices, such as the devices that are on nearly every table here and open and either being typed on or written on. Oh, yes, please.
Thanks, Misha, for that question. And I don't want to put words in Rob's mouth. And Rob, you are welcome to comment on this. But, part of that work group that they're working on as well is not just the device, but also the data that has to go between the implant and an external device. So again, that would be a great work group for those that are developing those external interfaces to the implantable BCI to be able to work with that work group. Rob, any comments? Did we cover it?
Want to hear you.
Misha, we definitely welcome you to be part of the working group, and we would love any opportunities to interface with more devices.
Great. Thank you.
I'll ask my question next.
All right.
Since I have the microphone.
Go ahead.
Have you guys thought about, like, in 15, 20 years, when we've successfully got these devices in the market, how will you know whether the iBCI-CC has been successful in its mission, and what does success look like to you in the long term?
Say that, Rob. Thanks for that question. Actually, strategically, I believe it is in our charter that once we meet our goal of having iBCIs widely available and accessible to those who can benefit from them, then we no longer need to exist. So actually, that is written into our charter for that particular reason, to make sure that we are not always trying to stay in a continuation, but we have a very clear end goal. Lee?
Yeah, and I think on the way there, the deliverables, the public outputs are part of how we measure our success along the way to those 20 years. We know what, and we've just heard from the work groups, what the major issues are that are facing us. We're getting a sense for how to prioritize them and what to focus on, so that the first of these devices, as they move from pilot to pivotal trials, actually have, for example, outcomes measures that will allow a pivotal trial design to be approved, that we have some idea for how reimbursement might eventually happen, whether it's from CMS or private insurers or VA or elsewhere, that is coverage from VA. And quick note, part-time VA employee, nothing I say here represents the official policy of the Department of Veterans Affairs. Those are all signs of success, is that we're actually finding a way to these devices being available. And I would suspect that from the industry standpoint, part of that will be that the devices are widely accessible, that the devices are adequately reimbursed, so that all of the companies who have put in so much effort to create devices that will hopefully be demonstrated to be safe and effective, those companies remain at least solvent. And if not better, I suspect is of interest. Those are all signs of success along the way. But I would agree with Jen, as written into our charter, when there are a plethora of implantable BCIs, when they were getting to maybe second and third generations, and this is an established field that's serving its purpose of restoring communication mobility and helping people with neurologic disease and injury, I think we'll be able to declare success for the collaborative community and have a final meeting of the iBCI-CC. Our goal is to do it in less than 148 years, which I think, right? Yeah. So but I think 20 years is a good outline to be thinking about. Oh, what questions online?
There we go. We have a question from the Q&A chat box on Zoom from Lynn Braillemeyer. Some people inevitably don't qualify for clinical trials. How might an extended access protocol step in to provide yet more access?
FDA, can you provide definitive guidance on EAPs? The question again from Lynn. So let's think about both sides of this. The first is that all the clinical trials, of course, currently are being run under investigational device exemption. Those trials have inclusion criteria. Those inclusion criteria are purposefully designed in order to maximize the benefit to society, to minimize the risk for any individual who's joining that clinical trial, not because they're hoping to gain any personal benefit, but because they want to help collectively us to test and develop devices that'll help other people with paralysis. But yes, we, in our own research group, looking at Dan Rubin, who's sitting around here somewhere as well, and everybody in here has been approached by somebody who almost can be included in a trial, but is outside the inclusion criteria of those trials. There are ways to interact with FDA to ask the question whether that person may be able to be included in the trial. Those are kind of one-off discussions about a very specific individual. It's, of course, up to the sponsor investigator to have those discussions. If that sponsor investigator believes that that person in the trial would, again, serve the general goal of being able to test the device and somebody who represents a population, who would then inform the further development of the device and its assessing its safety and efficacy. So that's kind of the clinical research answer, where I'm comfortable saying all that out loud. In terms of expanded access from the post-market side, anybody in the room willing to offer some unofficial, non-binding something short of guidance or education? We're now talking about technology that doesn't exist, which is the one that is already approved for market. So, all right, silence in the room. So yes, David, there. Yeah, go ahead. Thanks, Dave.
I just encourage folks to look at the website for the expanded access program, and there's a few different ones. But if you as a patient think you qualify, if you're importantly a clinician involved in this, that would be something to review and then reach out to the team. There might be some interactions. You know, our goal is to try to get as much contributing data as Lee highlighted that can raise the general knowledge base for BCIs. But, you know, across FDA for drugs, devices, there are various expanded access programs.
Great. Thanks, David. Thank you, Lynn. Questions in the room? Questions online? Yep, there we go.
Hi, I'm Roger Bagwell from Actuated Medical. So what's interesting to me is my father died from Parkinson's 10 years ago. And we're curious talking to a doctor who treats patients with Parkinson's with using DBS probes about his process and whether some of the things we work on could help him. What the thing, and somebody touched on this earlier, but you know, the whole idea of adoption and why do people get implants or not. And it was surprising to me, particularly with my dad's experience as well, how few people with Parkinson's, and not everybody who has Parkinson's qualifies for a DBS probe, but even those who do, it's a shockingly small percentage of people that get that done. And this has been around now for 20 to 25 years, has pretty good reimbursement from what I understand. It's, you know, it's the most known. And the doctor was sharing his experiences were part of it is at his facility, there's 7 neurologists, I believe, that would see a person and then make the judgment whether to refer them forward just to talk about a DBS probe. And he gets almost all of his from 2 of those doctors. So how do you learn from that experience with DBS probes, which are, you know, relatively simple, relatively well known, and with the education piece, and it's obviously also the doctors. And how do you build that awareness and learn from DBS and Parkinson's?
That is a great question. And actually, thank you for highlighting that because we really look to the DBS model for Parkinson's of how can we learn to make it better as we are developing the clinical practice guidelines, understanding the user needs, understanding those risk benefit that not only that our regulators will make in their decision making, but more so those with lived experience. How are they making that benefit risk determination and when do they need to be introduced? Adina mentioned that when part of the mapping exercise was to really understand when people want to be introduced to this type of technology and when they might be ready. And also one of our challenges is what clinical practice will be making that determination or making that recommendation, and then how does somebody get to that right clinician that is knowledgeable about it? So that is one of our grand challenges that we have in the collaborative community, but there are case examples like the DBS light retinal prosthesis that we can learn from, and that's part of what our groups are working on today.
I just want to quickly comment on that. I think maybe a year ago now, the National Academies hosted a workshop on deep brain stimulation and standard of care. You know, I think in the device space, we often look towards cardiac and implantable pacemakers, all those, you know, there's no question, but Parkinson's, you know, 8 to 10% of eligible patients. So that's still an ongoing group. So for those interested, you know, either through the collaborative community or individually, you know, to read the download from that and also participate in the working groups there because they're trying to do that. And then this community can build on that and sort of advance it as well.
Thanks, David. You said many of the things I was going to say, and I will just emphasize, very sorry to hear about your dad. I think that experience that you relayed to us of trouble getting to the device and that device ultimately becoming available perhaps later than it should have is something that we as a community want to avoid. And we're going to learn from that ongoing experience with deep brain stimulators. And we have a ton of education to do at every stage of the kind of provision of healthcare. We don't have a pathway that is as clear as one should be for getting a deep brain stimulator for Parkinson's disease or other movement disorders. So we have a lot of work to do. I think we saw a great video kind of introducing what the iBCI-CC does, similar outputs from all of our input about what we should be teaching the wider media, the wider group of people who may benefit from iBCIs, what these technologies can do, what their benefits will be. It's going to be incredibly important. And then we've got a whole nother set of education for healthcare providers, whether that be neurologists or neurosurgeons or PM&R physicians or speech and language pathologists or occupational therapists or physical therapists. any number of other clinicians. We have a lot of work to do. I think that work is actually going to be kind of fun, and it's going to be very productive to make sure that when the right patient in that kind of clinical scenario identifies themselves as potentially being somebody who would benefit from a brain-computer interface, that there's not then an 8-year gap before somebody says that out loud, that it's actually top of mind. There's kind of a pun there. But it is one of the first things that somebody says that an offering for potential treatments or ways of managing the symptoms of that disease or injury. So thanks.
Yeah, I'm Lance Combs, and you are right. I had the my final DBS implantation in April, and I only got there by a patient advocacy. I was the one pushing for it over and over and over. The first time that some medical professional said you might be a candidate for PCI. She said, but don't tell anyone that I recommended this to you. And that was 10 years ago. So it took a lot of luck and hard work to get that. And I hope that going forward, the kids for iBCI will not be as arduous and painful and really hurts than a kid for getting a DBS.
Thank you, Lance. Thank you for sharing. It is such an important message. It is such a key reminder that the experts in so many ways of that will be teaching us all at every step are not the academic researchers, are not the medical device developers, are not so many other groups, but the true experts are the people with lived experience of severe speech and motor impairment or of any of the other types of conditions that would lead one to potentially benefit from a BCI. It's you just very clearly told us how in DBS this has been a challenge. And the good news is that we're early enough in this field that hopefully we're going to be able to achieve just the goal that you said, which is to lower the barriers, to speed the referrals, to make it clear that somebody could benefit and how they could benefit, to have an informed, useful, accurate discussion with their clinician about the risks and benefits of the technology. So I couldn't agree more. And thanks so much for saying so.
And Lance, thank you so much for talking about your struggles. A lot of people are not willing to talk about that publicly. But just to add on what Lee had mentioned, I think the key thing we have to remember is that patient advocates are a voice and a very important voice for us to listen to and understand the struggles that they have been going through so we can have better access for them. And it's not always going to be, someone that is so bold as Lance to really push hard for somebody that's living with the condition. It might be a caregiver. It might be a family member. It might be a spouse or a sibling. So we have to think about who are the other stakeholders that are helping to advocate and how can we learn from them of their struggles so that we, when they come to looking for an iBCI, that it's not that they have to be the big key advocate in the healthcare system. How do we help solve that problem? And patient advocates and people with lived experience, we can learn from them. Thank you, Lance.
So I'd like to recognize that I'm a former regulator who always thought about the trust fund and always thought about program integrity. So deeply respect and in fact listen to a lot of the advocates, but lived through some of the decisions that we made, including around the monoclonal antibody decision. So my question is, how do we get innovations faster, which I'm fully supportive, but then continue to collect the data to say who should get it? Because if you look at pharma and you look at some devices, and my colleagues at the FDA may acknowledge that we don't always get the post-approval data that you have actually asked for. And the only real threat was for me coverage with evidence development to get that data. I think you have to ask that question of who does this work for how long, so that you really can maybe get it earlier, but steer it clearer over the 5 to 10 years after it's in use.
Yeah. Thanks. There are, I think, several people in the room that could speak to the hopes for that. From my perspective, the opportunity to collect those data serves two great purposes. The first is knowing that those data may be collected later, is it does allow us to innovate now, to push now, to try to get those pilot trials completed, to get those pivotal trials designed and completed with whatever collectively is believed to be the reasonable number of people to look at both safety and early efficacy in these devices. But what I hope, seeing other medical devices, is that whatever generation 1 is of the first devices collectively from the companies that make it through pre-market approval, that it is not the last device that they create, that they too are innovating, and that they're innovating in part from that real world experience that's gathered, hopefully, and continue to be gathered as soon as the devices are approved and are available for market. So I think, bless you, I think it's incredibly important for us to be thinking about that. We do think about the neural data itself. We're thinking about the outcomes measures. We're trying to figure out which of those outcomes measures are actually very clearly viable as outcomes of health and outcomes of improving health. And hopefully we'll be able to track those well beyond the initial approval of the devices. There are others that may want to comment on. Yeah, please. Yes.
I had a two-part question. Question one was, I had to write it down just to be sure. So sometimes, as you know, laws and guidelines become archaic with time and with changing technologies. And usually if you find that it's harder to remove something than adding. So how do we place policies and practices in place within the iBCI-CC, which allow that we constantly check for the need of removal or amendments of guidelines and practices being developed here or in place already at any given time? So that's question one.
All right. Can I ask you to pause there? Because yes, otherwise you'll test us to remember the first question in a moment. Which, yes.
We're going to call.
Okay, we're going to put him on the spot. We've got some ideas, but Dan Rubin apparently wants to help answer that question. According to Jen French, I'll help, but Jen said you should start. Yes. What is what can you speak a little bit about what your work group is doing to help us think about policy and practices within the iBCI-CC and in part related to clinical practice guidelines?
Sure. Wow, I didn't know it was going to be the spot. So to the extent that we can, the clinical practice guideline group, as I mentioned during the brief presentation, we've been going through, to the extent that we can, synthesizing all the data that's out there. So what has been done about for BCIs to date, trying to the extent that we can take a critical eye to the data that's out there, which data is generalizable, which data is specific to certain instances, come up with a series of questions and figure out which ones can we answer and which ones can we not answer. And when we went through the process over the past year, we realized we've got a pretty good sense of, what indications, what particular, what sort of indications have people explored, potentially using BCIs as a benefit for. That's an example. And we can list all of these, but can we say conclusively, that all indications have been covered? Of course not. And so we sort of put a stop point there. What we're now trying to do, and that's just one example, and there's many other things that came up, what sort of imaging needs to be obtained. And again, we reviewed the different imaging protocols that have been conducted, but again, recognizing that we can't make strong recommendations. This is how you should image someone before they place a BCI. We're now going to be spending the next year having sort of amassed this data, turning a critical eye to the question of what data do we need to gather so that we can answer these critical questions and make some recommendation. And at the same time, we're doing so deliberately through the lens, or we're going to be doing so through the lens of a clinical practice guideline where we evaluate the quality of the data. So what is the class of the data? Is it randomized clinical trials? Is this observational data? Is this expert opinion? And then from that, what sort of recommendations can we make? What additional research needs to happen? And so we're going to be highlighting research goals and saying, all right, these are areas where we've got some good answers. These are areas that are totally unexplored. And so perhaps for the early feasibility and pilot studies that are coming online, as you're gathering potential exploratory endpoints, start looking at these numbers, looking at these values, looking at these metrics so that we can begin to get a sense of what the data actually looks like. And then also working on things like how do we support users in different settings. And so thinking about what are the core components of key centers and looking, and this comes back to Parkinson's disease, which has come up a number of times. And there's a number of other examples, centers of excellence for things like treating people with epilepsy, where you've got a board of individuals who come together and decide, all right, these are people who should or should not get a particular intervention or surgery or procedure or device. Another classic example a lot of hospitals have are tumor boards where they decide how they're going to treat people who have a particular type of malignancy, and you get a multidisciplinary team together and make an evidence-based decision. So we're going to try and review all of the literature there, come up with a roadmap where we can gather the data we need to, so that hopefully the next iteration is going to be coming up with some guidelines. But we recognize that the guidelines of the past, the sort of static, clinically I work in the neuro ICU, so I look at a lot of the AHA guidelines. They put out really great guidelines for management of acute stroke and other conditions like that. These are sort of static documents, and you look at the 2020 guideline and you can see it has changed from the 2010 guideline. But in speaking with the folks who developed these guidelines, and this is something that came up at the ANSR workshop earlier this year, was moving away from static documents and finding a way to create living documents that are updated over time. So developing a formal framework for integrating new evidence as it arises. So there's a new paper come out, there's a new study that's published, having a way to turn around the expert review of that data, synthesize it into our guidelines, and put out sort of interval updates to it so that we stay current. That's our hope, and hopefully that will provide at least some basis of guidance. And then, our hope is that, of course, the community would coalesce around that and sort of support it and, point out where we've gotten it wrong so that we can, keep moving forward.
Dan, I think that's great. And that just to underscore that last point, for us, the good news at the moment is that we don't have to worry about revising something that doesn't yet exist. So we're in a good place right now where we are creating, just as you're implying, the very first sense of a guideline or a practice pattern. But I think my sense of this group, both online and in the room today, and all 490 of us, is the technologies are new, the opportunities are new, and I think the flexibility that's built into these initial paths is something that'll continue, but it's important for us to keep an eye on. We don't 10 years from now want to be looking back at something that we've written today and feel that it's stale or in some way no longer applicable. We really want it to be forward-looking when we write it and flexible kind of down the line.
Thank you for that. This actually goes counter to your bylaws of closing down shop early, because this is a continuous process, unfortunately. So the second question I have is more about, I think it's partly answered already, but I'll just mention it anyways. The guidelines and the practices being actively developed currently, how are we making sure that they are intelligently applicable rather than somewhat that is carpet, rather than be a carpet coverage, which sometimes leads to being a burden rather than helping the process. Does that make sense? So the guidelines and the practices that we are developing right now, if it's possible to make sure that they can be intelligently applied to a given technology or a given use case or a given indication, rather than a carpet requirement across technologies, across use cases, across, how are we making sure that that exists inherently in the guidelines and the practices that we are building right now?
Yeah, it's a great question. I've got some initial insights, but I'll look. Nope. Okay. The way that I think about this is that the way that we've set up the work groups and the way that people are participating in the work groups really is, even within each work group to the extent possible, it is a multi-stakeholder group. That multi-stakeholder group not only includes people with lived experience of paralysis and medical device innovators and manufacturers and academic researchers and patient advocates and ethicists and regulators and others. But it also hopefully commonly includes more than one representative from the medical device companies. And there are so many common challenges that we have. It's why we're all here. The first thing that we need to do is to try to address those common challenges. And my hope, and kind of bordering on my expectation, is that as those consensus statements are being produced and being iterated within the work group, through us as organizers, back to our signatories, which represent many of the medical device companies that are already engaged in this field and perhaps more in the future, that if something just doesn't feel right or is just wrong or is counter to the production of any particular device, that we're going to be hearing about that early, and that more than likely is going to have an impact on what that final statement is. Because we do have so many common challenges that I think you're absolutely right. There is a chance, I think carpet was the word that you used, to try to blanket and inadvertently suppress innovation in the process or counter one's approach to innovation. I think the good news is that we have enough common challenges that we need to address that we'll be able to do so for quite some time. But if somebody suggests something that just doesn't feel right, please tell that person, that particular approach may not be useful for a particular device, may be counter to the strategic approach of a particular company for any reason. It may not actually help the people who are trying to help with neurologic disease or injury. And I think our collaborative community, like the other 17 plus collaborative communities, are really set up to try to iron those things out as early as we can.
And if I can just add to that as well, is that we have 7 work groups that are addressing different types of topics, but you touched on something that's really important, is that these types of questions don't always sit very neatly into one work group. So there's a lot of cross collaboration between work groups. For instance, we pointed to Dan who's leading our clinical guidelines, but there's also the user priority work group that is really trying to get a good understanding of those use cases. So that's where working with the co-leads of these various work groups and working together and cross-pollinating what we're trying to solve can help address some of these broader questions.
Yep. All right. Got some questions online.
All right, so we have 2 more questions online, and then I think we need to wrap up. And one more here. Okay, we can go a couple minutes over, but yeah, we need to wrap up in a moment. So we have a question from Chaitali Biswas. How does iBCI-CC aim to include graduate students and aspiring researchers in the movement for standardizing BCIs? Are there any campus outreach programs being thought of? It may be less challenging to introduce iBCI to the next generation if they are familiarized with the technology from their student/early researcher days.
What an awesome question. So to I believe possibly the student that just asked, I'm not quite sure, but that is a great question. First is at iBCI-CC.org. In the upper right-hand corner, there is a little bluish button that says join. We would encourage any student, graduate student, undergraduate, or otherwise who is interested in this field to hit that button and then to join the work groups and begin to learn from other experts in the field and begin to contribute to the field in that manner. So we are a wide open organization. We are really interested in having students. Where's Joyce? Hi, Joyce. The example of an intern. I'm not pointing in the room. I think there are lots of opportunities to join this field. Also, there are many people who are in those work groups who often, as a side job, maybe not exactly right, who has another responsibility, maybe teaching either undergraduates or grad students or postdocs in any number of the neural engineering, neuroscience, applied psychology, and other programs around the country that are central to BCIs. I do think to the public messaging and education work group, I know Chloe was representing before or somewhere in the room. Hi, Chloe. I think this is a good example of another important kind of target audience, which is how do we get the education about this field out to undergrads and grad students who may be interested in applying everything they're learning about science and technology to be able to move this field forward. So I think it's a great question. And I'll just say, go to the website, hit join, and please join us.
the great plug. Last question from the chat from Sander Siegert. How does iBCI secure that in the standardization, we do not end up with USA, European, and Asian versions, such as we have nowadays with power plugs?
Anybody want to take a swing at this one? Rob, would you like to comment on the international components? I was gonna, didn't want to demand. Please.
The challenge is we have to think about these things from the beginning and think about them as we're designing the components, that how are they going to fit together with existing technologies like smart homes and computers and smartphones? How do we talk to those devices and ensure that as manufacturers are building iBCIs that enable people to communicate more effectively in new ways or enable them to work and interact with the world and their environment in new ways, that those are also being thought about all the way to the end rather than just how do we build this thing in the first place.
Great. Thanks, Rob. I think we've got one more question. Looking, Jessica, for permission. Yes, we have one more question in the room. All right, and we'll wrap.
Hello. Yeah, similar to the last question, actually. From an international perspective, the regulatory requirements across different jurisdictions and different countries are significantly different. I was just wondering if there's any efforts from iBCI-CC to include representatives from these alternative jurisdictions, or are we focused very specifically on US?
Yeah, thanks. You've responded to this before. Okay, I will. So Rob's going to keep going. Okay, Rob, you've got to respond. We both can. Go right ahead.
So we're in the process right now of setting up a liaison to the IEC and are looking at setting those up with other standards organizations as well also. And the hope is that as the world is internationalizing more, many of these standards are accepted by consensus in multiple countries and in many of those countries. And so by focusing on standards that are not just US-centric standards, but are international standards, we believe we'll be able to address that.
I'll also add, although I don't know that I'm right, maybe I'll look for silent nods from those in the room who know that I believe that some of our regulatory agencies do have the opportunity to interact with out of US regulatory agencies that may have a common interest in this field. And I'm seeing a nod. So yes, so we'll ask.
Yeah, just underscore Lee's point. We do talk with a large number, but not all international regulators, and there's probably ways and efforts we could do to even harmonize that. Open to suggestions, but we try to communicate, de-risk when possible. Try to talk through what sort of efforts other groups might be doing. As we're probably all aware, in the U.S., we're driving a lot of these efforts, but there's certainly a large number of groups out there that we talk to across the world.
Well, wonderful. And with that, I think we will close this year's iBCI-CC Q&A. So thank you for all of your questions, both in the room and online. And I will press the button, looking for the next slide. All right. Button in the front of the room isn't quite getting us there, but I'll let our colleagues in the back advance to the next slide. There we go. Thank you. So we will now move to our keynote lecture. We'd like to thank our sponsor for providing funds to the iBCI-CC for part of this meeting and including our keynote speaker. So our keynote speaker today is Malvina Eydelman. Dr. Eydelman, I first met kind of through documents, which I think at that point were actually submitted in paper. I will date myself a little bit. Which was my only intent. The circa 2000, somewhere between 2006 and 2008 or 9, somewhere in there, where then as a then young, hopefully still young researcher, developing and doing some early testing of implantable brain-computer interfaces. Of course, I, like others in the room, submitted things to FDA. And when those things were finally right that were submitted, you get a letter saying so that you could actually do what you'd proposed. And back somewhere in that time, I would receive those letters that were very short and matter of fact, that said something to the effect of, you haven't said anything really offensive, so yes, you can go ahead and do what you said you were going to do. Which was great. And some of those letters came from Dr. Eydelman, who at the time was the director of DONED. Now, DONED at that time was, if I can get it right, the Division of Ophthalmologic, Neurologic, Ear, Nose, and Throat Devices at FDA. Just imagine for a moment a division of ophthalmologic, neurologic, ear, nose, and throat devices all in one place. That's kind of early to mid 2000s, roughly. And just think about all the progress that's been made from a regulatory organizational standpoint now that we have such a well-focused kind of division now of neurologic and physical medicine devices and the expertise that they bring from across science and engineering. So, but I always really appreciate it. So thank you for those signatures. And Dr. Eydelman is really a pioneer in medical devices, in ophthalmic medical devices, and in really guiding the evolution of lots of parts of this field of medical devices, including on the ophthalmologic side. She recently, and I think she'll speak more to this in just a moment, became the CEO of the CCOI, the Collaborative Community on Ophthalmic Innovation. She has an extraordinary perspective on collaborative communities and the good that they can do to advance implantable and other medical devices. And with that, just really a pleasure to welcome today's keynote speaker for the iBCI-CC annual meeting, Malvina Eydelman.
Thank you very much, Lee, for that lovely introduction. I am truly privileged to be here today. Thank you to the speakers, to the organizers for inviting me. Thank you to all of you here, not just for attending, but for being part of the shared vision of collaboration. You know, in preparation for today, I was trying to think about what meaningful insights can I give this outstanding group. And I started to reminisce and try to think about my career. I retired from FDA, in March after 30 years. And thinking back, you know, collaboration has really been the cornerstone of most of my achievements. Going back through all of the different hats I have worn, and if you think donut was bad, I essentially at one point or another was in charge of all the different devices from the diaphragm up. But, you know, really collaboration has been the success for every achievement in my career. When I started back in '95, most of the clinicians thought of FDA and definitely CDRH as a black box. Heck, even I didn't know much when I was offered the job for the first time. And, you know, I spent the first 10 years basically changing the paradigm and trying to explain to the world what FDA does. I started by what at the time was unheard of, talking at professional meetings as an FDA rep. I started writing my own column in iNet, which is one of the, I'm an ophthalmologist by training, in one of the ophthalmological journals. Then I really pushed my leadership and membership at the time to start writing more guidance, and I became first standard representative at the ANSI American level, and then I became the representative to US ISO, which is International Standard Organization, which, you know, just as a representative of the whole United States, not just an FDA. And through the first 10 years, I realized that, you know, that kind of talking collaboration is really what broke down the silos. That's how the conversation started. That's how the world understood that to move the innovation forward, we all needed to work together. We all needed to speak the same language. Then about 10 years in, I became one of my first jobs as a director of the division of, at the time, I started with ophthalmics and other parts kept being added. And as I was thinking about what I wanted to achieve in leading my team, I realized I didn't really want to do more of the same. I really wanted to figure out a way that we can move the innovation forward expeditiously. And to do that, I knew that we had to figure out how to come up with novel endpoints for brand new technologies. We couldn't really do the same thing again and again and expect a different outcome. And I also knew that even though FDA is huge and powerful and had tens of thousands of people across all of the different centers, we at FDA still didn't have all of the expertise that were needed to really make that change. So I started partnering as a division director at the time with everybody, all of the stakeholders in the medical device ecosystem. And as you can see, there are many, and this has been brought up several times this morning. Every single stakeholder has a different voice, has a different opinion, but all of them are important and all of them need to be heard and all of them need to be considered in order not only to get a new technology or a new medical product approved and on the market, but then to get accepted. And there were wonderful references to deep brain stimulation, which I was dealing with for a couple of years. And I'll give you more examples. Again, you can get wonderful technology on the market, but still have it not utilized. So starting these conversations early, getting everybody involved, I knew was really essential. And with that, I became the queen of workshops. This is just what fitted on one slide because I decided to spare you. But I had many, many workshops over the years that really delineated a way forward to brand new technologies. Now, my talk is only 20 minutes, so I decided to just give some of the examples which I'm most proud of, or which I think had the most impact. And one of them was bringing the first FDA AI device that performed diagnosis without physician input. The very first autonomous AI for all of medicine was for something called IDXDR, which was diagnosing diabetic retinopathy. And my team did that. And I think that truly changed the paradigm, not just for ophthalmology, but for all of medicine. And as you know, AI, not just for the eyes here, but AI for all of medicine is here. Another one of very unique collaborations that I'm specifically proud of is collaborating with patients. At the time, 25 years ago, 30 years ago, it was still the doctor knows best. We all knew how to evaluate the medical products. The clinicians knew how to evaluate the patients, but nobody really asked the patients what did they think. Was our assessment really consistent with their aspirations? So I started this incorporating of patient voice into medical device assessments. I led one of the biggest PROs ever co-sponsored with FDA, with NIH and DOD, which resulted in something called PROWL, which became the first ever medical device development tool for performance in ophthalmology. And then I continued my passion for incorporating patient voice. And before I retired, actually ended up with 4 PROs that are now utilized widely. As Lee mentioned, I also had the honor of leading a number of neurological advancements. And that, too, I did through collaboration. Again, I'm going to spare you the time, but there were quite a number of firsts that I was able to push through, specifically because I figured out how to bring the professional organizations. A lot of work was Johns Hopkins, a lot of work was academia, and that was truly the only way to get the neurological advancements at the time, because Unlike David, when I inherited that division, I did not have any neurologist or neurosurgeon, so I had to be really creative. So with all of my successes in collaboration, when I heard that in 2018 that FDA was considering collaborative communities as one of our CDRH strategic priorities, I volunteered to help I don't know why these slides are going on their own, sorry. I volunteered to help make the first one a success. So it was right around the same time, as I said, there were quite a number of workshops that I have been running. And as you can see by the number of emblems, some of these workshops ended up with about 17 different co-sponsors. The Forum on Laser-Based Imaging, you can see on those, those signs. So we truly felt, and Stanford Ophthalmology Byers Eye Institute was the convener for a lot of these. And so it was a natural progression for Stanford Byers Eye Institute to become the convener for the first ever collaborative community on ophthalmic imaging, which was formed in 2019. At the time, the mission was to clarify challenges, best practices, strategies, and standards while advancing innovation in the ophthalmic imaging space. In 2019, we had professional organizations, government agencies, academic institutions, manufacturers from US, Europe, Asia, and South America. So right away, we knew that we wanted to make sure that this is a global entity, and we were very strategic in sort of looking at the map and tapping our colleagues from around the globe to make sure that the consensus we generate is truly global. In the first 5 years, CCOI has proven to be a huge success. It became a 501c3 in 2020. We have published very impactful peer-reviewed publications, and so much so that we actually generated a special issues in the most prestigious journal called Ophthalmology, dedicated to the role of AI and digital imaging. We were very successful and obtained BAA, something that David referred to, in order to assess impact in autonomous AI to reach historically underserved populations. We also started a global registry for something called age-related macular degeneration. Sorry, I have abbreviation, thinking it's an ophthalmic slide. But AMD stands for age-related macular degeneration, and we started a global registry. Now, our cornerstone has been our virtual conferences. As you saw, we started in 2019, right around COVID. So being virtual was not an option. It was sort of, we were forced into that, but then we realized that virtual conferences for a global entity actually worked very well. So between 2020 to 2025, you can see the stats. Our conferences reached about 1,300 registrants per conference, and I was really proud when we got all 7 continents. It happened that somebody I knew was visiting the 7th continent, but we normally got 6. Now, within the last 9 months, the scope has undergone tremendous expansion. And we did that very creatively. We kept the abbreviation, we kept the I in CCOI, but the I from imaging became I in innovation. And as you can imagine, the scope just went huge. So right now, we're covering all of the innovation, devices, drugs, biologics, combination products. If you can think of it, we're talking about it. Also, within the last year, we started something called the Stakeholder Council. Which is a global forum to accelerate ophthalmic innovation. And the photo down below is our inaugural picture of the Stakeholder Council in-person meetings. The rest of the folks were online, but there were about 100 people in the room. It's essentially allows anybody in the global community to join specific meetings and provide feedback to the leadership about what are the hot topics that CCOI should address and recommendations on how to move forward. So within the last year, CCOI truly became the rule engine for ophthalmic innovation. As you can see, it now unites all stakeholders on the global medical product ecosystem, including patients, researchers, manufacturers, investors, clinicians, regulators, payers, and advocacy. In March, I retired from FDA, and 3 weeks later, I became a CEO of CCOI, trading my FDA hat to my permanent CEO hat. And with that, we did some regrouping, and I wanted to make sure that our mission towards the future is very clear. So this is now our updated mission: to remove the barriers between groundbreaking ophthalmic medical products and patients who need them, but also, and this is new as of this year, to unlock the eye's full potential in innovative medical products to advance both ophthalmology and the broader healthcare. And this is something that all of you are going to be starting hearing more and more. It's called oculomics, and I will share some more slides about this. And in the last 6 months, we have done tremendous amount of work to create an efficient ophthalmic ecosystem for innovative medical products. I'm really excited to tell you that within the last months, we were approved as an independent member organization of the American National Standards Institute. CCOI now has an official delegate to ISO. Moreover, we now have 1 out of the 5 seats at the ISO level for all of ophthalmology in the United States. Don Calagiro, who used to work with me for all of my years at FDA, retired from FDA, is now chairing the standards for CCOI. So as a result, CCOI can now influence ophthalmic standards development in defining test methods and requirements to advance the approval of innovative ophthalmic medical products, both US and internationally. And what's even more exciting, we are now in a position to propose the developments of new standards. We have also grown a little bit in the last 6 months. This is the current structure. I now have 17 work streams. As you can see, we have an executive committee, and the way we organized it is similar to standards because I have been the ISO delegate for about 25 years of my career, so I guess I think in the same way now. So we have horizontal groups and vertical groups, and horizontal groups as the light blue, and the vertical as the dark blue, and the horizontal, as you can see, do the cross-sectional items that are relevant to all of the disease spaces, and the dark blue as a specific disease area. We also have a stakeholder council that I referred to, and then additionally, in the last few months, we started a resource development advisory committee in order to help us maintain this structure. Now, considering how large it is, there's no way that I'm going to bore you with details about every single work group. I'm glad my work group leaders don't hear me referring to them as boring, but everything is very exciting. But I will only touch upon the items which I think you will find interesting. So learning remains essential to innovation. And with that, we are very as you saw, one of our horizontal work groups is called education. We're continuing with all kinds of meetings. I showed you the specs for our virtual meeting from 25, but this year we have really changed the paradigm, and we're hosting a number of very frequent in-person meetings. So the first one we did was at Stanford in July. I just flew back from Paris, where we hosted a myopia consensus workshop, again, global. And then, as you see, we have a pretty busy schedule, and this is just for the next 9 months. We basically have a meeting or two every month going forward. And the excitement and the enthusiasm around the globe is just overwhelming. I mean, we really can't keep up with the requests for these meetings. There's not enough of us to clone to make all of this happen. And as you see, we're also trying to be cognizant of the geography. So we do US, then we did Europe next. We're doing Hong Kong in February, and so we keep going around the world. We also establishing something called CCOI Innovation Academy. I was very impressed by the education piece that I heard, and I really loved the video. So whoever put it together, I'd love to talk to you during lunch. But we realized, just like you, that without education, the innovation is not really going to reach our targets. So we're thinking of doing it a little bit differently, a lot more targeted. So we haven't done it yet, but we're envisioning a patient education portal where a patient can type in what disease or condition they have, and then have the system pop up what medical products are available in that geography, and have a patient-friendly, sort of like a patient labeling short version of what it does and what clinical trials are available for their condition. Something similar to healthcare provider as well. Now, what I think that we're way ahead of many other collaborative communities is our innovation fellowship. Exactly 10 years ago, the Stanford Ophthalmology, I say we because I'm an adjunct at Stanford, but started Ophthalmic Innovation Fellowship. And at the time, it was the first one, and I was truly honored to have an MOU with my FDA hat. So every single one of those fellows has rotated with me at FDA, and it was a tremendous experience for each of them. Now they're all very well-established academicians around the globe. But they all had this incredible opportunity of being at Bayers and then spending a whole year with my staff at FDA, learning about regulatory for ophthalmic devices and how to integrate that. We are really continuing this with training the next generation of innovators. Many of you probably know about the biodesign program at Stanford. So our innovation fellowship at Stanford is joined together with biodesign. And this year we have actually moved the Bias Innovation Fellowship, which used to be only US based, under CCOI. And now we have a Global Innovation Fellowship. And I already have a fellow from Hong Kong who is wonderful. I have 3 fellows from all around the globe, and we're starting to get more and more interest around the globe for additional fellows. This is our meeting in July, which I guess was just a couple of months ago. And it's, there's so much enthusiasm for what we do is we'll learn the next generation how to be a true innovator in this space, what it takes. And one of the pictures on the left you see is actually Michael Abramov, who was the person responsible of bringing the first autonomous AI to market, talking to the students about lessons learned. So what we do is we bring successes and we bring what we call the failures. And there's just as much excitement and enthusiasm to learn from both. Clinical trials work group. So this is something that I don't need to explain to this group. So even though the subject matter is different, the problem is the same: challenge, high cost, and complexity of clinical trials. So what we decided to do as CCOI is to develop an ophthalmic clinical centers of excellence for the world. Right now, we're in the process of creating a global consensus on the criteria for clinical center of excellence. And what we're doing is we're compiling existing global standards and consensus for each of the measurements and developing the standards where consensus is lacking. And next, what we're going to do is, once we have that done, we're going to be establishing a robust training and certification process to designate clinical sites as global centers of excellence. So CCOI is going to become a certification body. And hopefully 5 years from now, anybody who wants to study a novel ophthalmic medical product can just decide that they want one in China, they want one in Brazil, et cetera, and we can give them a list and say these centers have been certified and know how to do this well. This is, again, this might look specific, but there's a reason for my madness here. I wanted to talk about this because I thought you'd find it interesting. So my first degree is in engineering, and I always think in block diagrams. This is just a preface. So what we did is we took a new disease. So we're doing, obviously, still a lot of work on AI, but we were trying to figure out how to bring artificial intelligence to one of the most common diseases, which is age-related macular degeneration. So what we did is we, as an engineer, basically plotted. We got the diabetic retinal disease screening algorithm to market. So we plotted what is it that we had that allowed us to get there. And then we did the same exact thing for AMD, and we just, turned the red as the boxes that were missing. It sounds very simplistic, but nobody has done that before. So with that, we said, so what do we need to do to get AI for screening for AMD to the market? And we realized that what we're really missing is a benchmark data set for AMD screening. So what we did, as a result, we put together a prospective cross-sectional multi-center observational study to collect and develop a meticulously curated and diverse AMD, yes, I still have FDA at heart, and diverse AMD benchmark data set, which is featuring reference standard classification and comprehensive annotation of images. So we're going for about 1,000 patients around the globe, and you can see from the map that we really do need to have a diverse data set. And again, this is specific to AMD, but I just want to show you the different approaches and different creative ways that we're approaching problems at different work streams that I thought might be of interest to you guys. We are continuing to utilize all different avenues to expedite AI. And some of this is very relevant to this morning's conversation. So looking back at the lessons learned from diabetic retinopathy, we got the first ever autonomous AI for screening to the market. But even today, the penetration is less than 3%. So we have done a lot of looking back, lessons learned, and trying to figure out what can we do for that, but mostly for everything that's in the pipeline to get everybody ready so that when the technology becomes ready, then you can really penetrate the market, have an acceptance. So while we're continuing to develop foundational principles, we're also working already on establishing gold standard endpoints for efficacy assessments for the technologies that don't exist yet, the ones that are still in the pipeline, because they're not going to get to the market unless we as an entity create those gold standard endpoints. We're also putting together, in the process of finalizing, reimbursement work group. Michael Abramov just presented in Congress about a month ago about the CPT code. He was instrumental in creating a CPT code for AI and how to use those lessons learned for all of the technologies that we have in the pipeline. So we're putting together a brand new work group and really stressing thinking about reimbursement before the technology hits to market. Again, I know I'm preaching to the choir, but I really thought that all the conversations this morning were very relevant and very consistent with what we're doing on a big scale. And again, scale utilization. About a month ago, I had the privilege of being asked to chair consensus for Asia Pacific on maximizing AI utilization for diabetic retinopathy screenings. The reason I bring it up is if you think the penetration is better in US, when you go to Asia Pacific, the penetration is just awful. So they were actually trying to learn from me how to increase their penetration. So the point is everything is relevant. But what can we do to maximize it. So we need to do patient education. Again, I'm repeating the same things that all of you said this morning, but just to show that it's not unique to BCI, it's really is the same issue across all novel technologies: patient education, physician education, optimizing workflow implementation, and reimbursement. Now, this is my favorite topic. If you don't remember anything from my talk, just remember the word oculomics, because in 5 years, all of you will know it. Oculomics is what's the second part of my mission statement now is. Oculomics is what's going to change the world. Oculomics is the hottest thing that's coming down the pike. What is oculomics? Oculomics is a science of analyzing ocular data, imaging and other, to extract not only ocular insights, but systemic health insights. And we have a lot of different modalities that we use, both for imaging and for fluids. I mean, as you know, tears are very easily accessible, and there are a lot of other biomarkers. Eye is basically just hanging out there, the easiest thing to touch, to feel, to see, and it's truly the window to the eye, and that is why I was debating actually early in my career between ophthalmology and neurosurgery, and then I ended up in ophthalmology. I still love neurology, but. And this is just another representation to show how AI basically takes the data from ocular imaging and combines it with other risk factors. So it's basically multimodal AI. And there is a tremendous amount of wonderful data showing its very good precision, especially for neurological diseases, for cardiovascular, for renal, as well as for anemia and some other systemic diseases. But this is not the future. This is already the present. And I truly believe that oculomics is what's going to really connect us to all of the other to the primary care providers, to the pharmacy. It's basically the things that is the glue. It's going to allow early detection. It's going to allow increased access, enhance equity, and decrease the cost. And as the number of eye care AI approvals is expected to increase exponentially in order to be able to accommodate all of these systemic indications. And as you see, NIH has already recognized it as well by putting out this Office of Strategic Coordination grant. So what are we doing unique at CCOI for oculomics? We're standardizing global image acquisition. We're defining gold standards for diagnostic endpoints. We're enabling reimbursement through data-driven evidence, and we're empowering patients with education. And no other group in the world is doing this. So that's why right now I put this as a second part of our mission. I truly believe CCOI is uniquely positioned to make oculomics a reality in the next couple of years. And, as I said, every one of my 17 groups is doing something truly exciting and wonderful. But I have to admit, the most inspirational group and the most inspirational folks I ever worked with is the Mary Tyler Moore Vision Initiative. For those of you who are old enough in the room, hopefully know who Mary Tyler Moore was. And we have partnered, CCOI have partnered with Mary Tyler Moore Vision Initiative to create what we call Diabetic Retinal Disease Cure Accelerator, which we call a moonshot for eliminating vision loss from diabetic retinal disease. For those of you who might not know, Mary Tyler Moore was diagnosed with diabetes as a young woman and devoted a large part of her adult life to raising awareness of the devastating consequences of diabetes and its complications. And she was an optimist at heart. She thought that anything was possible. This is Mary and her husband, Dr. Robert Levine, who's now become a close friend of mine within the last year. upon Mary Tyler Moore's death, he promised that he will do everything in his power to create a world without vision loss from diabetes. He's a cardiologist by training, but by now he knows more about ophthalmology than many of my academic ophthalmic friends. So with them, we really have a very, very intensive work stream, and we'll basically have something going on with the DRD Cure Accelerator every month. So I'm not going to read all of this for you, but I will talk about the 2 sessions we're doing in October, because I think that they're pertinent to all of medicine. We're doing something brand new for all of the healthcare. I have partnered with something called NADA, which is a company out of UK, which has never done anything in healthcare before. But it's an AI platform that drives organizations that most human insights possible from the most people possible instantly. So essentially, you can have one session for 1 hour for up to 20,000 people from around the globe, and then AI synthesizes what was said by whom within that same day. So with that premise, we have now put together 2 first-of-a-kind sessions using DRD as a pilot. We hope to use it for all other disease entities going forward. On October 27th, we're having a session called AI-Driven Insights, Advancing Consensus on Diabetic Retinal Disease Endpoints to Transform Medical Product Developments. Essentially, we're going to have hopefully more than 10,000 stakeholders who are involved in the diabetic retinal disease medical product development come online and answer specific questions about the appropriate endpoints. And I'm very fortunate that my FDA colleagues are collaborating with us, and we're trying to see if this can be the beginning of AI-driven Delphi process. So it's very exciting. We're also going to be partnering with, Delphi gurus out of Cornell this is a first session, which is hopefully going to be the beginning of a brand new way of reaching consensus on endpoints for medical product development. Likewise, on October 30th, we're doing a similar session, but just for patients. We're calling it Driving Faster Cures in Diabetic Eye Disease, but essentially, this is a pilot on trying to utilize AI for PRO creation. As I said, I did 4 PROs. The first one took about 12 years. Well, I already retired once. I don't think I have that many more retirements left in me. So I really if I want to have an impact in PRO space, I want to make sure I come up with a creative way. And I'm very fortunate that Ronald Hayes, I don't know in this room how many of you know this, but this is somebody who was a PI on all of the ophthalmic PROs that have been ever recognized by FDA and NIH, is the co-lead on this work group. So under his leadership, I have Dr. Sahel and Dr. Ron Hayes, who are pioneers in PROs. And here, if you go look up to the right, I put it in yellow. It's the work group. It's called Vision Assessment and Outcome Measures. And I think that's very relevant to this group, because we're basically looking at very creative ways to assess outcomes, functional outcomes and PRO, and we're trying to maximize AI and trying to trying to maximize the N, because we're doing it virtually and not in person, not in small rooms, but trying to see if we can do one session with up to 20,000 patients around the globe to try to come up with a way to move that field forward. I know my time is coming to an end. So the other group, which is the most relevant to this room, is our group on vision restoration and rehabilitation that is being chaired by Dr. Joseph Sahel and Mark Humayun, who most of you know for their work in the retinal implants. And I'm really delighted that David is part of that group. And this group has set out to, They are determined to, I just had a conversation with them about 2 weeks ago, and they're very excited to re-engage iBCI collaborative community, because we understand that the endpoints and the clinical trial design, there's enormous amount of overlap. And just as I basically like collaborating any which ways, the more creative collaboration, the more excited I get. So I'm definitely totally thrilled for that group to work very, very closely with this community. Right now, the group was just focused on making sure that they finally submit the manuscript from our workshop, because as you know, FDA its publication was a little slow this year. So they're submitting that manuscript and writing an editorial about how that is going to be the foundation of going forward. And as they're working on developing consensus on clinical endpoints, the message from Dr. Sahel and Dr. Humayun is to please reach out either to them directly or through me. They want to engage all of you as much as possible. Again, since the eye is now innovation, it's no longer just implants, it's biologics, it's drugs, it's genetics, it's basically anything that you can think of. If it has an impact in that space, they want you to contact them. So hopefully you have seen that innovation does not bloom in silence. It rises where minds meet, where differences ignite, and where purposes align. And so I would like to urge all of you to move past the limits, rethink what's possible, and shape a future only we can create together. Thank you.
Dr. Eydelman, thank you so much for that incredibly inspiring message. I feel like in many ways we are the little sibling of CCOI, and if we can be even remotely as successful as our big sibling, that will be a truly wonderful thing. So thank you for showing us how this is done. There are all kinds of ideas in there that I know resonate with the folks that are here today and online, whether it's the fellowship, which really caught my eyes, just caught my eye. That was good. As one of many opportunities for us to think about in this group. So thank you for being here, and thank you for sharing with us. With that, I believe we are now going to go to lunch, and this is where I look at the boss. Okay, and for how many? Right, until what time? Until 12:35. All right, so for those of you here in the room in Baltimore, it's lunchtime. Lunch is outside. We will reconvene here at 12:35. You'll probably be eating your lunch, the same chair you're sitting in at the moment. So grab your lunch, come back in. If you're online, please return at 12:45-ish. Probably. Oh no, sorry. Go ahead.
If you're online, the afternoon portion will not be available online, but you're welcome to return to the group, I think at 3:45. 3:45 for our debrief. So everyone attending virtually, return at 3:45. Everyone here in person, 12:35.
Wonderful. With that, enjoy your lunch. See you back here at 12:35 Eastern if you're here in the room. Thank you all for being here today. Thank you for taking an entire day. Thank you for your continued contributions to this collaborative community. I too was at many, if not all, of the work groups for at least a few minutes. I heard great conversations. I heard some serious debate. That's exactly where we should be at this point in our evolution, are having good points with equally good counterpoints, and trying to find our way towards consensus on the issues that are really vital to getting from where we are to devices that are demonstrated to be safe and effective and available and reimbursed and widely and equitably distributed. So very excited to get there. It's really like party people in the house. I don't know what that's over there. Continue those great discussions, continue them through our work groups. We and the organizers of the collaborative community are here to facilitate that however we can. probably the most important thing that I will say up here is that if you registered for today and you're here in person, if you registered online and are there virtually, if you've had any yogurt-covered pretzels or any coffee, or you've networked with each other, or you've noticed a banner on the front of the podium, or you've got a booklet in your hand, that's all because of our amazing program manager, Jessica Kellman. So please, Jessica, thank you. Really does an amazing job in bringing us all together and moving this field forward. So thank you, Jessica, for everything you do. Our second annual meeting, we still have things to learn. We want your cards and letters, so keep sending them. And please give us feedback on what you would like to see for the next annual meeting, what you'd like to see from either our Slack workspace or from the work groups that are meeting virtually regularly. And I believe that Jessica covered nearly, I think, just about everything else. I will look to Jen and Joe. Anything else that we would like to say there? The year ahead, we're going to see continued pilot clinical trials. We may see the first of the pivotal trials. We'll find out that that emerge as well. This is going to be a big year for our field, and we still have a lot of work to do. Thank you for our colleagues from FDA who are here, from CMS or formerly from CMS, from VA, from NIH, the presence of current and former federal employees, together with our representatives of medical device companies, people with lived experience, ethicists, academic researchers, patient advocates, and so many others who are here. It's only because you're all here having these conversations, challenging each other to try to figure out how we get to these endpoints that we will succeed as a field. Thank you for your time. Thank you for being here. I look forward to seeing you over there near the window, facing the window, in about 3 minutes. We will take one picture and hope to see at least some of you over at James Joyce to continue the networking starting at 5:30. Thanks again for being here. Have a great afternoon.